हेलो।
हेलो।
Yeah, Siddharth, yeah, can you hear me?
ओके ना सर?
Yeah, it's fine. Now, can you give me this? Can you call me up, please? Can you call me up?
ओके।
फोन कीजिए।
हेलो।
हेलो। अच्छा, तेरा ऑडियो बंद करो जरा सिस्टम पे। जूम पे ऑडियो बंद करो।
ओके ना सर?
हेलो। हेलो सिद्धार्थ। हेलो। हाँ सिद्धार्थ, अभी देखो ये लाइव तो लाइव नहीं गए ना अभी तक ये। आपका लाइव। अच्छा, लेकिन आपका लाइव रिकॉर्ड अगर है तो एक्फा का वो वीडियो चलाओ ना आप फिर। नहीं। हाँ, और ये लिंक अभी हम लोग आपके डिजी ऐप के थ्रू कैसे आ सकते हैं वो तो जरा समझाओ हम लोग को, कि डायरेक्ट लिंक दे दे लोगों को। हाँ, ओके, डायरेक्ट देते हम। और ये ऑडियो चालू करो, ऑडियो चालू करो। ऑडियो नहीं है। हाँ, वीडियो आ रहा है, ऑडियो नहीं है जरा।
But that's an
example.
Challenges. For example, image quality can be affected by equipment and external limitations. ऑडियो आ रहा है ना सर? How can the technologist?
हाँ, आपका आवाज आ रहा है, रिमूव मत बात करो उसके साथ। और अभी डॉक्टर अनबरासो आएंगे, थोड़े स्क्रीन पे जरा हेल्प करना उनको फिर। हाँ, आप रुको, होल्ड ही करो। हाँ हाँ, ठीक है, अभी चलने दो। जब भी वो आते हैं तो आप मालूम पड़ेगा ना आपको आ रहे कि नहीं मालूम पड़ेगा आपको। ठीक है, 2 मिनट के बाद आप ठीक है, आप स्टॉप करो, शेयर चल रहा है ना। हाँ हाँ हाँ, तो होल्ड करवाएंगे अभी।
A further clinical test compared results using Musica 3 Chess Plus to tests using an anti-scatter grid. This study concluded that while grids may offer more favorable results in the controlled environment of an X-ray room with wall stand, in the challenging domain of mobile and bedside chest imaging, Musica 3 Chess Plus non-grid further clinical test compared results using Musica 3 Chess Plus to tests using an anti-scatter grid. Musica 3 Chess Plus concluded that while grids may offer more favorable results in the controlled environment of an X-ray room with wall stand, in the challenging domain of mobile and bedside chest imaging, Musica 3 Chess Plus non-grid first plus studies carried out in our white paper. Musica
Sanjay, I'm having some problem. I don't know. My can you hear me now? No, I'm through the computer. I will just go mute here on my cell phone. Can you hear me now?
Yes.
Yes. Okay, can you hear me?
Yeah.
Okay, better. And shall I go share screen?
Okay, you can try.
Is it better? Are you able to see it?
Yeah, it's fine. This is good.
Okay, I don't know. My
Yeah,
video
yes, Arsu.
is my video. Sanjay, is my video is green in color for some reason?
It's all right. You need an upgrade, you think?
I don't know. It's still working okay. This camera.
This is fine.
Now it's playing up. It's okay. Oh, Mitisha.
It's playing now. I think it's stable now. It's stable now.
Okay. No
Good
problem.
evening, sir.
Good evening, Mitisha. How are you?
Fine, sir.
Super. So, Sanjay, is there any formal remarks to start with at 8 o'clock?
Yeah, we start sharp 8 o'clock. Yeah.
Yeah, so
I will just
Okay.
begin.
You will be starting with.
Yeah. I'll just begin the session and then we'll introduce Anbarasu sir, and then we can just take over with the first.
Okay. Thank you.
You can start, Mitusha, if you think. I think it's all right.
Okay, sir.
Yeah, go ahead. Yeah.
You have 123 or somebody already online.
Yeah.
Okay, sir. So I shall start, na?
Yes, please go ahead. Yeah.
So good evening, everyone, and a warm welcome to this online CME on conventional radiology, the Masterclass, as we all know, Back to Basics by AGFA and the Ages of Indian Radiologist. This is one of the most popular sessions, especially among the exam-going residents, and hope there is a lot to learn from our expert speakers in these 2 days. So today's program, as you all know, will start with the abdominal radiographs by Dr. Anbar Asu sir, followed by sessions by Dr. Upreti sir on HSG, also by Dr. Sanjay Yadav sir on DRU and ASU, then something about barium studies and exam spotters. Tomorrow morning, we are going to start at 9 a.m. sharp with all those important topics, as you can see, starting with the X ray of the chest and moving ahead to the orthopedic part. So, without wasting much of time, I would like to introduce our first speaker, Dr. Anbar Asu sir. Sir is a senior consultant radiologist and also the director at Aran Diagnostic Imaging Coimbatore. He has been examiners to many of us, and he has been examiners for various board exams, various publications to his credit, and even book chapters. Sir has received several awards, including the Rohan Williams Gold Medal at Final FRCR. We welcome you, sir, and thank you for joining us today. Over to you, sir.
Thank you, Matisha. Thank you, Sanjeev, for having us today. And as you know, Masterclass has been, should I go for share screen? Yes. Has been a sort of a turnkey event, which is sort of has been traveling to all the places in India, all the major 4 cities. But unfortunately, the last leg couldn't be completed, but we are now online, so which is a good thing. So hope this is still beneficial to everyone. So let's start straight away with the abdominal radiograph. Right. Okay. So abdominal radiograph. The plain abdominal radiograph is actually less well taught because it is not often done. It is commonly done by urologists, whom they don't send it to radiologists to interpret it because they know what they are looking for. But it's important for 2 things. One thing is, if they have a doubt, if the surgeon or the urologist have a doubt, they will come to you. And that is where, if you sound like as though we don't know anything, then it will be a problem. We always say immediately we'll do an ultrasound, we'll do an CT. But sometimes plain film radiography is where your respect starts. So the objectives today is understand the radiological anatomy on a plain X-ray radiograph of the abdomen, because that's important. Then what would you look for in a chest X-ray? Like that, what would you look for in an abdominal X-ray? Because every X-ray you should know what to look for. If you don't know what to look for, then you will obviously going to miss that particular abnormality. So we should have a systematic analysis in a slightly simpler way, which I'm going to teach today. And we have to just look at the end, what are the indications for abdominal X-ray in the current concept of ultrasound and CT taking over the abdominal imaging. So just simply in few slides, let us see the radiological anatomy, so that you will start believing what you are seeing in the abdominal radiograph is actually the important one. So look at this particular abdominal radiograph. If I tell you that, I'll just go for the pointer options. Okay. So if I tell you here that this is the outline of the liver, and this is the outline of the both psoas shadows, and there is outline of the kidneys in this area. some people believe it, some people actually don't believe it. And there is actually this abdominal fold due to your belly, which is forming a shadow here. There's actually an urinary bladder is there. And obviously you can see all the bones. Okay. But if I put up an MR by the side, then now you start believing, yes, we can see the inferior liver margin, which is outlined by the abdominal fat. And therefore we are supposed to see the inferior liver margin on abdominal radiograph. It's actually a different patient. And then if we go back, we can actually look at the outline of the kidneys. We are here, we can see the psoas outline. We are able to see that on the coronal T1 weighted MRI scan. So now we start believing, yes, whatever we are seeing on MR, we actually has been seeing in the abdominal radiograph. As you can see here, that the psoas outline are given in the black margins, and the bladder outline is here in the black. And there is the renal outline in the black line here, dotted line on the right side. And there is a splenic outline is mentioned here. So as you can see that the same anatomy can be appreciated on the MRI as well. So we will be able to see all the soft tissue opacities, which we'll be able to see on the MRI scan of abdominal pelvis on abdominal radiograph. So you will be able to see the normal soft tissue pattern. The next thing you should look for is the normal gas pattern. And you should always understand there are normal calcifications. When I say normal calcifications like phleboliths, atheromatous calcification and aorta, they always sometimes mimic like a stone. So you have to be a little bit careful. And the bones, how does a normal bone or an aged bone look like? And these are all the 4 important areas we are going to look at today. So what are we going to look for in abdominal radiograph? Obviously, you look at the name and date of birth and make sure it belongs to the correct patient, and systematic approach is important. But systematically, you look at the calcifications, you look at the bones, you look at the soft tissues, look at the gas patterns, and simply put, it is my teacher, Dr. Merchant, taught me in the science, stone, bone, gas mass, like a mnemonic. It's just easy to remember. Abdominal radiograph, what you're going to look for, looking for stone, you're looking for bone, you're looking at the gas pattern, you're looking for any soft tissue lesions or mass lesions. Okay, so there are 4 different densities which you would see on any radiograph. This is obvious, like a soft tissue density mass, or a low density gas or fat, or a high density stone or bone. These are all the 5 different densities, and the other one is the metallic density. 4 or 5 different densities which always seen on every plain radiograph, and we should start appreciating it. So if you repeat few times in your mind, okay, stone, bone, gas mass, in live conferences, I actually asked the audience to repeat it so that it goes into your mind. So at least in an abdominal radiograph, this is what I need to look for. So if you look at the gas pattern first, there is gas pattern can be normal or abnormal in terms of obstruction, abnormal in terms of wall thickening, because the outline of the gas pattern becomes abnormal, and you should always look at the gas at the abnormal location. When you're looking at a mass, you're looking for soft tissue density lesions, and looking for stone is calcification at various places. We all know about renal stone and gallstone, but there are various other things which we should look at. And bones, I'm not going to touch today because bone abnormality is entirely, completely another topic. But key thing is to, you should have a cursory look all your spine, all the iliac bones, both hip joints, symphysis pubis, superior and inferior pubic rami, femoral neck, and at the corner of the vertebra, corner of the film, you will be able to see your intertrochanteric region, and also the ribs and the sort of D12L1 region. So these are all your areas of, there may be lesions which will be lurking in this, particularly in exams. So when it comes to gas pattern, you will be seeing dilatation, thickening, and the location of the gas pattern. So let's look at the dilatation, right? So the measurements which you use it on CT or ultrasound is not real on plain radiograph, because there is some degree of zooming effect which always happens. But what you're looking for is looking for air fluid levels. Air fluid levels will be seen only when the X-ray beam is horizontal. So you might want to take an erect view, which many of the surgeons ask. But as per clinical indication, you don't need to. You need to have only 2 X-rays in an acute abdomen. One is a supine abdomen radiograph, and the other one is your erect chest X-ray. So how do you look for small bowel obstruction? Is you see folds, if they go across the bowel, then you are dealing with small bowel dilatation. The diameter is generally more than 3.5 centimeters abnormal. The central location and air fluid levels. And these 4 points tells you that we are dealing with a small bowel obstruction. the folds tend to go across the wall-to-wall location, obstructive inguinal hernia causing this appearance. So it's very important looking at the hernial orifices in this particular location. Okay, now this is a small bowel obstruction due to hernia. Now look at this particular appearance. There is small bowel loop dilatation. As you can see, the folds are going across. It is central in location. And what we are seeing is the lamellated calcification at the pelvis. It's a typical gallstone ileus. It's an exam case in the FRCR or even in all MD-DND exams. So when you see that, you immediately look at over the liver and look for any gas in the biliary tree. And that's a clue, and combination of these three findings makes you a typical diagnosis of gallstone ileus. This is again supine abdominal radiograph. You can see this is an erect chest X-ray. These two combinations should always be done in a patient with acute abdomen. In this particular patient, there is a small bowel dilatation. There is no free gas, and there is interpreted as something obstructing at the level of proximal ileum, distal ileum, or at pelvic level because the dilatation is proximal to that. And on the CT scan, what we are able to see is a wall thickening and narrowing in this particular area, and this diagnosis of an adenocarcinoma of the small bowel loop affecting one of the ileal loops, resulting in obstruction. Coming to large bowel obstruction obviously results in large gas shadows going across the margins of the abdominal radiograph. But only thing is there can be redundant loops of sigmoid, redundant loops of transverse colon, which makes confusion as to what we are dealing with is either large bowel or small bowel. So that's something which you need to be careful enough. The haustral folds are there which do not cross the entire width of the gas shadow. It is located around the edge of the abdomen. Diameter abnormality is if it is more than 8 centimeters, you regard it as abnormal, especially when the transverse colon, they say it's about 5.5 centimeters. It's abnormal, and when the cecum is more than 10 centimeters, there's a sign of impending perforation. And air fluid levels may be there, may not be there. Often it is less often seen in a large bowel obstruction. Sometimes you can see abrupt cutoff, and that is a very, very useful sign. And presence of rectal gas does not exclude obstruction, because it's a well-known fact that rectal gas may or may not present in patients with obstruction. Previously, there was the old paper which said that if you see a rectal gas, then it's unlikely it's a large bowel obstruction. And there's a pseudo obstruction which can happen in elderly people. It can mimic like obstruction, and you have to be careful before saying that this is actually due to large bowel obstruction. So this is a 56-year-old female with pain and abdominal distension. And as you can see, small bowel loops are dilated. On the right side, there is also dilatation of the large bowel loops here in this area. And you can see it's going across like this. And if you start giving if you go back, just look at here, the transverse colon also a little dilated. We are not able to see very well what's happening to the descending colon. But the simple water-soluble contrast actually confirmed presence of an apple correlation in this area and confirms the proximal dilatation of the proximal descending colon. The distal descending colon and rectosigmoid is not dilated. So this is a large bowel obstruction due to colonic carcinoma, is one of the common causes. We should be able to pick it up. And this is another elderly with abdominal pain and distension. When you start seeing this in the exam, everybody will first say cecal volvulus. But then the next question to the examiner will ask you is, how do you differentiate this from sigmoid volvulus? And this is a confusion which often people have in the exam. One of the important clue is look at the dilatation of the rest of the large bowel. If you look carefully, you can see there is dilatation of the ascending colon and dilatation of the transverse colon through this particular big dilated gas-filled loops. Okay, you can see it is converging towards the left iliac fossa. So the presence of proximal bowel dilatation makes this obstruction at the distal to the transverse colon, and this appearance is typical of actually a sigmoid colon, sigmoid volvulus. So as you can see, sigmoid volvulus, there are several signs which has been discussed in your book, but not all signs will be present in every patient. So you have to see about 10 different sigmoid volvulus in your Google search, and you will see how each one is actually different. Okay, and sometimes you can do a contrast enema, which will show this bird beak sign or twisted area of sigmoid volvulus, and you can see the dilatation of this proximal colon, suggesting the obstruction is actually at the region of the sigmoid colon and confirming this is actually a sigmoid volvulus. And this is another patient who has got dilatation involving the large bowel, as you can see. And you can see in this area, we can actually see a filling defect. And there is what looks like a little coiled spring-like appearance. When I say coiled springs, I'm sure most of you have already thought of the diagnosis. And you can see on the CT this particular bowel within a bowel appearance. And in an adult, you have to chase that bowel within a bowel appearance because you should find out a lead. And the lead cause here is actually a colonic polyp. Okay, intussusception presenting as colonic polyp presenting as intussusception. The gas-filled distended loops can be present, not small bowel, not large bowel, but can be any of these. There are specific conditions where it can be dilated. One of the things is here, sentinel loop on the right iliac fossa suggests that there is an inflammation going on, and commonest is an appendix abnormality. This is a cecal valvulus where the dilatation is involving the cecum, which is abnormally located. You can see that the ascending colon and transverse colon is actually not dilated. This whole thing is actually part of the cecum. It is not dilated, so there is proximal obstruction in this area. And the sigmoid valvulus, as I showed earlier, and the obstruction involves at the level of sigmoid, therefore the proximal colon is little dilated. The other sentinel loop can also occur. The colon cutoff sign happens in pancreatitis in this area, where the transverse colon gets dilated up to that, and after that there is edema and collapse of the distal colon. Now let's go to the gas outlines, out of which we have seen the dilatation cause, small bowel and large bowel dilatation and the possible causes, and then the thickening. So look at this. This is a normal small bowel folds which are about a millimeter or two in thickness, and you can see here large bowel history is also not very much thickened. It's also very thin, about less than 2 to 3 millimeters, and you can see that here it is actually not crossing the entire length as we saw earlier. And any bowel wall thickening, you can close your eyes and say causes like this: inflammation, infection, and neoplasm, and you will be right in the exam. But in terms of small bowel and large bowels, there are specific conditions which will come in the exam. Is small bowel hemorrhage, edema due to low protein congestion or malabsorption, connective tissue disorders like systemic sclerosis can be shown in the exam as a cause of small bowel wall thickening and dilatation. So here is a patient who has got a slightly gas-filled transverse colon, but you can see the classic thumb printing you start seeing here, and these areas actually represents your colitis appearance, commonly ulcerative colitis. And you can confirm that with your contrast edema if you want, and you start seeing sometimes pseudopolyps in a slightly later stage. And here also colitis as seen on the CT scan. The gas outlines, the thickening is something which is appreciated on your CT or ultrasound much better than a radiograph, perhaps except colitis, which you should be able to pick it up on the plain radiograph. Come to gas locations. It can be located intraluminal and extraluminal. Intraluminal is usually part of dilatation, but in extraluminal gas is important because it's a classic question: how to look for free gas in a supine abdominal radiograph. And this is again shown by the examiner. They like it, and there are several signs which you have to look at, and you can see this: there is a free gas overlying the liver, and that area should always be soft tissue density, but here we are seeing loosened density. There is an air which was shown earlier at the level of falciform ligament, just subhepatic air, and you can see that there this is an area which is just outlined completely loosened, and this is the falciform ligament sign. You can see that there, and you can also see the classic Wriggler sign. You can see both walls are sharply outlined due to gas outside as well as inside, which you all know, double wall sign or Wriggler sign. These are the signs which sometimes can be shown, either single or combination of any of these. And this is a patient who presented with sudden severe abdominal pain and low back pain, and you should start appreciating where there is a gas is actually outlining the kidney. That means we are dealing with the retroperitoneal gas, and there is a sort of a muck or a heterogeneous moth-like appearance, a clumped appearance of bowel loops and soft tissues, and gas pockets are there, and this suggests that there is actually a collection with retroperitoneal air. And you can see it on CT. There is a retroperitoneal perforation in this particular patient from the duodenum resulting in collection. It has been going on for some time, but the presentation was late. And you can see it's outlining not only the kidney, but also the aorta, which is showing an aneurysm as well. And here is a patient who has got a slightly enlarged liver. And if you look carefully, you will start seeing the branching pattern of gas located within the shadow of, within the outline of the liver. And this is air in the portal tracts. As you can see, the portal tract blood flow is towards the liver, and therefore it tends to reach the periphery. You can see the branching there. So this is portal vein gas, which is not a good sign. It's an ominous sign. You can see it on the CT, and it is associated commonly with bowel mesenteric ischemia. You can see necrosis and gangrene of the small bowel loops. And this is a bad sign. This is another example of a gas. This is at the abnormal location. This is, you can see here, there is this common bile duct is beautifully outlined, and you should start immediately searching for small bowel obstruction or a stone elsewhere. This is sort of faint stone, which was demonstrated here in this patient with gallstone ileus. Another patient who has got a stone, but we have to look at a little more carefully to look at the lucent area of the tubular structure, which is the common bile duct. One of the more common causes nowadays that gas in the biliary tree is due to presence of post-surgical changes or post-ERCP changes. So air in the biliary tree, gallstone ileus. So gas patterns, obstruction, dilatation, wall thickening, gas at abnormal location are the areas we should look at. Let's look at a little bit about mass and the stones. Let's go to the stones first. Okay, we all know that the phleboliths are often seen in the pelvis, and one of the common clue is stones tend to be above the level of ischial spine, as you can see here, and the phleboliths tend to be below the level of ischial spine. This tend to be a very, very useful thing, because most of the ureters actually come and join the bladder above the level of ischial spine. That's sometimes a clue. People say there is some central lucency may be there in phleboliths, but you know, there are people who demonstrated that ureteric stones sometimes have central lucent areas. And this is a typical diagnosis which you might want to make in exam. If you start seeing tooth-like structures in the pelvis, little bit of lucency around it, straight away it is a dermoid, and this is a very straightforward, probably a spotter which you shouldn't make more than 2 seconds to identify it. Okay, another area where there is a brush-like appearance of the calcification in both kidneys, a typical appearance of medullary sponge kidney. So these type of calcifications, you should have it by heart, and you know, you should not have any second thoughts about it. Another area of lamellated calcification, which you can see here, like an onion, and that is the gas in biliary tree, again a gallstone ileus. Okay, and here there is an area here, as you can see, little bit of soft tissue density in this area, and if you look carefully, there is a small calcification which is shown. And when you have a soft tissue density at right iliac fossa with the stone, immediately you should think about appendicitis, appendicolith, and appendix mass. Another patient who has got a calcification which is in the shape of gallbladder at the right upper quadrant. That means it is a typical porcelain gallbladder. And unusual question in the exam is, would you have to take it out? Yes, because there is a small risk of malignancy is there. It's a typical calcification, multiple dot-like calcification going across in an oblique plane from the right side to the left side, a typical shape of pancreas. This is a chronic pancreatitis. And you all know these foreign bodies, which are everybody is able to identify. This patient was a drug dealer caught in the airport, and there was a lot of things which are sort of hid in the rectum. And this one, I think most of you know, but most of the time patients say, I haven't done anything wrong. And this patient has got few stationary swallowed. Renal colic. Renal colic is an important area because plain abdominal radiography is often done because of various things. They wanted to know where the stone is, and they wanted to see the size of the stone, density of the stone. They can make a judgment, the urologist, reasonably with the radiograph. Ultrasound has replaced it, but whenever they are going to do some sort of an intervention to take some decisions, they need renal colic. But the X-ray KUB is the one which they do it. Phleboliths versus stone is something which we should be confident of. Limited IVU has been proposed in the past, but the CT KUB has become the gold standard to identify a ureteric stone. And we all know that how sometimes the mid and lower ureteric stones has limited appearance, and if it is not causing obstruction, but a good radiologist with good in ultrasound will be able to identify most of the stones. And it is amazing how, you know, people are picking up mid and lower ureteric stones just with ultrasound. And typical tag on calculus, as you can see on the plain radiograph, CT scan. The urostones are about 90% calcified, so it's always seen, while the gallstones are only 10% calcified. Fecalith can be seen, dermoid can be seen, mucinous tumors can have calcification, but don't diagnose these as pathologies, which are phlebolith calcification, sometimes lymph node calcification, vascular atheromatous calcifications, and fibroid calcification. These are all almost like a normal variations depending on the age. You shouldn't mistaken that for an abnormality. So what we have covered the gas patterns, we have covered the stone diseases, and we have to look at the soft tissue mass, and the bone is something which will be covered as a part of the bone pathology talk. So this is a 45-year-old patient with vague abdominal pain, just vague abdominal pain, but the radiographer, the radiologist who interpreted this is, probably reports around 2,000 to 3,000 X-rays in a month as a part of his reporting sessions. And he picked up this, he reported like this: few gas-filled distant loops, a small bowel, residual fecal residue, but he saw there is something like an apple core lesion forming a gas pattern in the rectum, which may or may not be significant. And he simply said rectal examination is advised. And as you can see, patient present with vague abdominal pain. Even that time, probably this was taken about 20 years ago, the clinicians, stopped doing rectal examination. Nowadays with corona, and the clinical examination is now done at 6 feet distance. So therefore, you have to suggest the simplest way is to feel the rectal examination, and the patient actually gone back to the clinician and said yes, he felt something there, so he sent back for confirmation, and the sort of simple barium study, contrast enema was done, which showed that apple core appearance. And you can see that here on the contrast study, the water soluble contrast, and here you can see that zoomed plain radiograph showing that typical apple core appearance, which was able to confirm it on 2 months later. And this sometimes happen in some countries. The plain radiograph was interpreted beautifully by the radiologist, and who advised correctly what should be done. And so soft tissue mass is something you should get to train your eyes to look at on plain radiograph. And neoplastic mass, intussusception, you know how to look for the typical bowel within a bowel appearance, hepatomegaly, splenomegaly. These are all the things which you should be able to appreciate on a plain radiograph. So the objectives of this is to understand the radiological anatomy, what to look for in an abdominal radiograph. We have covered most of the areas related to stone, bone, and soft tissue mass. And let's look at the indications for abdominal radiograph. What is the role here today at 21st century? The Royal College guidelines, which gets revised every 3 to 5 years, abdominal pain suspected of suspicious of perforation or obstruction or warranting hospital surgical consideration should have, or any patients with acute exacerbation of inflammatory bowel disease, these all tend to have an abdominal X-ray as their first test. Not everybody goes into emergency ultrasound, not everybody goes into emergency CT. Chronic pancreatitis, urinary hematuria, colic line pain, and follow-up for known calculi. Ingested foreign body, again X-ray is probably the best. Blunt abdominal injury or stab wound, particularly when there is a foreign body which is penetrating. Suspected intussusception pediatrics, again X-ray is done in most departments. And blunt abdominal injury is again a little controversial depending upon the article you read. But nowadays ultrasound is even replaced by CT scan. But again, some of the departments where the CT is available or not affordable, ultrasound and X-ray gives you combination of findings in relation to foreign bodies as well as soft tissue injury and free fluid. Abdominal X-ray is not indicated in acute GI bleeding, hematemesis. If you see a palpable mass, if clinically there is a palpable mass, there's no point in doing an abdominal radiograph. Go to the next level. Appendicitis is a clinical diagnosis, and ultrasound is the first test. Biliary disease is not indicated because ultrasound is far better, only 10% of stones visible on abdominal radiograph. Acute pancreatitis not indicated routinely because the staging and treatment is actually based on CT severity index. So just to recap, review areas, tiny ureteric stones. Okay, it's very important that ureteric stones are looked for. If you don't look for, you will miss it. Gallstones in small bowel, to diagnose gallstone ileus, you have to trace it. You have to have a little bit of patience in tracing it. Bone lesions, again, you should have a review area, look at the spine and pelvis. Air in the right upper quadrant, especially the free gas or air in the biliary tree or portal vein, is very, very important in terms of exams, and also occasionally it comes in your real life. Hernias are actually common, and that is something which a patient with obstruction you could diagnose with your plain radiograph. Lung basis has to always be, should be your review areas, because like in chest x-ray you will review the abdominal part, while in abdominal x-ray you should review the lung part. So simply a stone bone gas mass is your mnemonic, and these are your review areas. And thank you very much for listening today, and all the sort of 336 people who are online. Thank you very much, Mitisha. I'm happy to take any questions now.
Thank you, sir, once again for taking this very important and basic topic. But it is that we go and see for the complex ones, read them before the exam, but miss to read these things which are really, really important for us. So questions, I think in Q&A we can see one question that is, I think, just a revision, like a difference between cecal versus sigmoid volvulus on plain radiograph.
Yes. I just decide there. See, the sigmoid volvulus comes with various signs, convergence to left iliac fossa, the species coffee bean-like appearance. There is a central thin septum-like appearance. No hostile pattern, dilated lobes which is reaching up to the level of diaphragm. These are the signs discussed. But one of the most important, the cecal volvulus can sometimes mimic like that appearance. So what is consistently is always useful is look at your descending colon. If the descending colon is dilated, then the descending colon is dilated means the obstruction is at the level of sigmoid colon, and therefore this is sigmoid volvulus. If the descending colon is collapsed, transverse colon is collapsed, then the obstruction is more proximal, so it's likely to be a cecal volvulus. That is probably the easiest. So you train your eyes to look at the descending colon behind the dilated lobes of sigmoid or cecal volvulus. That is the most important.
Thanks, sir, once again. And I think the tips which you gave throughout the lectures are really important for all of us.
Thank you, Mitesh. I think there is one more doubt has been a number of fluid levels to diagnose small bowel obstruction and normal location of air fluid levels. See, number of three and above or more than 3 is regarded as a small bowel obstruction, but that's not always sort of useful. It's not 100% foolproof. Nobody is going to operate on if you see 4 fluid levels on erect radiograph. Normal locations of air fluid level, you all know that the stomach at the level of fundus, you can see fluid level depending upon the things. Duodenum, first part of the duodenum, you can have fluid levels, and some 1 or 2 fluid levels within the small bowel loops are allowed. So that's where that 4 comes in place, and you can always see sometimes fluid level at sigmoid or transverse colon due to just a simple redundant fecal matter and fluid. Thank you, Matisha.
Thank you, sir. Now let's move to the next session for today, and it's always an honor and pleasure to introduce our next speaker, Dr. Lalendra Upreti sir. Sir is our immediate past chairman of ICRI and dean at Rajiv Gandhi Super Speciality Hospital, New Delhi. The entire last year from ICRI, we had so many academic programs and session, and all thanks to sir for his vision. And today sir will be taking important topics, so stay tuned. The first topic which sir will be taking is HSG, yet another important topic for exam going residents as well. So we welcome you, sir, and over to you.
Thank you, Mitisa. And shall I share my screen?
Yes, sir.
Let's start with the first topic, which is so thank you to the organizers for inviting me here to deliver this talk. And this is the first talk I'm giving today. This is on hysterosalpingography, a lost art or a useful tool. Right. So let us, as more and more modalities are coming, so HSG, the status of HSG, it is not clear what HSG is useful for at present. Right. So just starting with where HSG should be done. This is something which we all need to remember, that because of the recent advances in reproductive medicine and a lot of assistant reproductive technology tool and increase IVF becoming more frequent, there has been a re-emergence of HSG, because you need to evaluate the entire genital tract in these cases, and for fallopian tube there is no better investigation than HSG at present. So in fact, although there have been multiple tools, the number of HSG being done even in Western world has increased over the years after this reproductive medicine has the use of this has increased, right? So this is used mainly as a screening procedure for infertility workup, and it is the excellent study for fallopian tube. As of today, it is, at least in India, it is the study to look for fallopian tube abnormalities, and it is also helpful in uterine cavity evaluation. Here it has high sensitivity, meaning that it will pick up the lesions, but low specificity cannot assign. Low specificity is there, right? And it has use in congenital uterine biomaterial and extrauterine pathology. Now, for these other investigation like 3D ultrasound and MRI, they offer better value as compared to HSG. So this is a place where it has found a limited utility, but because HSG in India, because of various factors, it remains still a very important investigation. So you would be seeing these abnormalities frequently during the course of your residency or your practice. So we'll be covering this also, but remember that it is mainly where the value lies in the evaluation of fallopian tube. Now, as I said, it is a screening procedure for infertility, and for evaluation of infertility, these tools are used in one way or another. These include transvaginal ultrasound, saline infusion sonography, contrast sonohysterosalpingography, virtual CT, HSG, MR, hysteroscopy, and diagnostic laparoscopy. Now, these are basically done by the gynecologist, and these are the radiological investigations. So let us just briefly review each of them where they are useful. So transvaginal, that is the modality of choice for visualization of uterus, evaluation of uterus abnormality and ovaries. The problem with transvaginal sonography is that the normal tubes are not visualized. Then we have this saline infusion sonohysterosalpingography. What is done is that saline is infused into the tube, right? First, the endometrial cavity is distended. Then as with the injection of this saline, this goes into the tube, right? So you would be able to see the uterine cavity very well. So you can distinguish between a myoma and a polyp or endometrial hyperplasia. And B mode and Doppler investigation, though, they also help. It is a reasonably good investigation if you want to demonstrate a patent tube, right? So what will happen if the tube is patent? The saline will pass through the entire tube, comes out through the fimbrial and into the peritoneal cavity. So you would be able to visualize the tube in the fluid in the pouch of Douglas. So patency of tube, that can be documented, but there is a problem that you will not be able to see where is the site of block. That cannot be documented exactly with the help of this investigation, and the condition of human is also not very well seen with the saline infusion sonography. All right. So this is a new investigation which is being increasingly used, and it is actually competing with HSG as a one-stop shop for evaluation of uterus as well as the fallopian tube. This is hysterosalpingo contrast sonography. So what it does is that it uses ultrasound contrast. So once the ultrasound contrast is used, so that requires a different kind of instrument that you need to be aware. Usually it's an expensive high-end kind of instrument, and you need to have a special software for that. So this uses contrast mode on scanner, again implying that you need a high-end scanner. The advantage of this is it is less painful as compared to HSG. It demonstrates the site of tubal block well. We just learned that in the saline sonography, although normal tube can be seen, we can reduce the presence of normal tube, but if there is a block, the site cannot be demonstrated well. So this site can be very well seen with tubal block. What happens is that there are these air bubbles which are introduced by this contrast agent, and a very high contrast is created between the lumen of the tube and the surrounding structure, the wall of the fallopian tube. So wherever this is blocked, right, wherever this tube is blocked, there you would see a very high echogenicity area, and beyond that you don't see that. So, and then you can follow it from the uterus, and you would be able in majority of the cases to determine what is the site of block. So that advantage it has. So it has higher sensitivity and a lower false positive rate. As I said, as compared to other investigations like HSG, it has less patient discomfort. And this is a big plus, no radiation to the patient. Problems, contrast media are not widely used. They are usually expensive. And the study takes, the learning curve is relatively longer. Operator dependence is there as with all ultrasound modality. And as I said, along with the instrument, you need a high-end instrument and you need a special software. So these are the limitations because of which it is not routinely being used in India, at least, right, for evaluation of tube. Although the current evidence suggests that this may turn out to be equally good. All right, so these are the other investigations, that is CT-HSG. This is basically HSG technique combined with MDCT. The advantage here is that you can see the uterine wall and external contour very well. Now this is required for determining the type of anomalies, especially the congenital anomaly. This is required. So that's the advantage with CT-HSG. Tubal patency and morphology can also be studied well. So you can, with the help of various these reconstruction techniques like 3D MPR, map images, and virtual, you can do a comprehensive evaluation of the uterus and the tube. As you can see very nicely, the entire uterus is outlined. You can see the tube very well, and there is free spill on this side. Little dilatation of tube is there. So good delineation of the anatomy, and in the source images you can also see what is the contour of the uterus and all that. So reasonably good investigation. And the problem here is that of ionizing radiation. There is too much of radiation, and the same information can be achieved utilizing other modality, and again it's an expensive proposition. Right. So MR hysterography is basically a sequence like MRCP, which utilizes heavily T2 weighted sequences. Now this particular sequence is suboptimal for visualization of tubes. We can also do MRI HSG. So what we do is we use that similar HSG technique, insert the contrast, the gadolinium contrast on the outside the MR, take the patient in the MR suit, and then examine it and take the images, so we can see the lumen as well as the tubes, and we also see the wall very well. So tubal patency can be determined, and this is one advantage of MRI because it has inherent high soft tissue contrast, so it is more sensitive to even smaller amount of contrast spillage. It is much better for congenital uterine biomaterial and extrauterine pathology, and presently after ultrasound, this is the one MR which is done for these indications. Right, it is free from radiation. The limitation are again the cost, the limited availability of this investigation, and of course it takes more time than HSG, right? Now we have these surgical and endoscopic techniques also, which are employed in evaluation of infertility. Hysteroscopy is basically the gold standard for uterine cavity abnormalities and simultaneous therapy. Diagnostic laparoscopy and chromoperturbation, we all know this is the gold standard for tubal assessment, extrauterine pathology, and again you can do therapeutic procedures along with that. These investigations are invasive and require anesthesia, and they are not done as a screening investigation. Usually you would do some form of imaging investigation and you're not able to reach any conclusion, or you find the pathology and you thus the gynecologists feel that this need to be treated with hysteroscopy. So in those cases, these modalities are employed. All right, so having considered all the modalities which are available to us for patient having infertility, now let us come back to our original talk, that is the HSG and see the pros and cons of this investigation. The benefits of HSG is that it is the excellent investigation for tubal patency. It is very good for luminal as well as peritubal disease. It has high sensitivity for uterine cavity abnormalities. It is readily available. You just need an X-ray tube and a fluoroscopy is always better. But at many places, this scan is done blindly also sometimes, and the images are quickly reviewed. They're usually done with CR or DR maybe, and the images are quickly reviewed. So we are able to do even with these without the availability of fluoroscopy a reasonably good investigation, but fluoroscopy is always preferable. It is a cost-effective investigation and it is easy to interpret, and it is a kind of objective investigation. The limitations are that the role is limited in congenital uterine myometrial and extrauterine pathology. It has low specificity for uterine filling defect. There is radiation involved. This is one of the major actually problem, that this is inconvenient and painful to the patient as compared to other procedures. So this is something we need to keep in mind, and we do the investigation in a proper way so that at least these complications are minimized and patient can be made as comfortable as possible. Now see, this is the ACR list in 2020, right? And for evaluation of female infertility where there is suspicion of tubal occlusion, what is the initial imaging modality? Here, the fluoroscopic HSG is right on top, right? So even in Western world, it is the investigation to be done. And as I said, that US sonohysterography with tubal contrast agent that is coming up, and that is actually being increasingly utilized for evaluation of uterus and tube because of this factor, that the radiation level is pretty high with fluoroscopic salpingography. So that is why this sonohysterography is gaining traction. Now, coming back to the indications, as I said, infertility is the prime indication. Then you would, especially in periphery, we would do this for recurrent spontaneous abortions, also to look for congenital anomalies. Post-op evaluation, this is definitely a recognized indication, at least in India. In India, the government runs a program where the people just a minute, please. So where the patient who undergo ligation, they are given some financial incentive. And these financial incentives are usually given when it is certified that the ligation is successful. So this is also one of the indications, and at UCMS, this kind of indication usually we used to do HSG at least once or twice in a week, right? And again, after reversal, ligation has been done and the patient wants the reversal to be done, and then again that the fact that tubal patency is restored, that has to be documented. So this is also one of the investigation. Now this pre-op evaluation before myomectomy, that is usually not required, right? Just remember, major indication infertility everywhere. This one, particularly in India, it is done for this purpose, for confirmation of that the tubal ligation has been achieved. Okay. Now, technique of HSG, that is very important. I would request you to focus on this aspect, right? Because in your department, you may be doing the investigation unsupervised. Okay. So you need to be very cognizant and aware about what is the proper technique. This I emphasize because this technique is painful for the patient. And if due to some factor which is in our control, we are not able to perform the indication properly and we need to repeat the indication, that is actually not on, and there should not be any need for repeat study if you are doing it with a proper technique. So learning a proper technique is very essential. So when this needs to be done, well, you know the 10-day rule that this should be done usually after the onset of menstruation. Bleeding would go on for 4 days. The restoration of endometrium takes some time. So A good time would be something between 7 to 10 days, not 12 days. 7 to 10 days should be a good time where you would see the endometrium would be restored. There would not be any chance of any endometrial shed endometrium which can lead to intravasation. All right. Always you need to rule out active infection. That is generally requires a gynecological examination and blood test also. So these are the two things you need to remember. Then about prophylactic antibiotics. See, many of the patients who have tubal problems, they have PID, especially in our country. So this decision is usually left to the clinician. That is, if the patient suspects, the clinician suspect that antibiotic may be required, patient may be having PID residual, which may not be clinically significant, but may get flared up after HSG, because that usually happens. It's an invasive kind of investigation. So this is left to the surgeon. If they want to give antibiotics, they can give, right? But if some complication have occurred, like if intravasation have occurred, then the risk of infection is increased. Okay, so then we have to prescribe antibiotic after the procedure is done. As I said, it's a painful investigation. Always, mostly analgesic is given, oral analgesic 1 hour before the procedure. That always helps in reducing the patient and getting cooperation from the patient. Well, spasmolytic agent not routinely required. It is when you see tubal spasm, you suspect tubal spasm in the HSG, then you may give. This is important that catheter or cannula, whatever you are using, whether using cannula or you are using a catheter, it should be primed with contrast. What does this mean is that you you just inject out all the air present in whatever the cannula or the catheter you are using, right? So what you do is, if you have a cannula, make it vertical, inject all with contrast, and ensure that the contrast comes out of the other side, right, in the erect position. So this is the best way to ensure that no air bubble is left. Okay, so just before introducing that, do this. So that way you can prime it with the contrast. All right, now these are some of the things which are used for devices used for cannulation. This you all know, this is Leach-Wilkinson cannula, most commonly used. This is usually used with tenaculum, where you can manipulate the cervix and change the position of the uterus if there is difficult cannulation. This is a metallic cannula. It usually has more discomfort for the patient. That is the disadvantage of this technique. But the control of the investigation is little better with these metallic cannulas. Then we also have this Econ tip cannula in place of Leach-Wilkinson. You can use this. Another advantage is that they can be reused. Then this is a dedicated HSG cannula, and this is what we do in India. We use the Foley's catheter. This is usually expensive. I don't know whether it is available in India, but yes, definitely with this Foley's catheter also we can do HSG. So you have called the patient, taken all the precaution, decided about the antibiotics, instructed the patient very well. You have to explain the patient the procedure in detail so that she is not surprised on table. You are going to tell what you are going to do, how this cannula is going to be introduced, what she is likely to experience during the examination. Do tell that pain is usually there, right? We will do everything for the pain, but then you have to cooperate and you should not be stiff. All right, after these after this explanation has been done, you ask the patient to lie on the radiographic table in the lithotomy position. But before that, you take control radiograph of the pelvis, right, to look for any calcification on any other shadow which can cause confusion on the contrast study. So what we do is, the patient is now in the lithotomy position, right? The parts are cleaned with antiseptics, usually povidone iodine. Then you look at the cervix. Okay, you again clean the cervix again with the povidone iodine. Then if you are using the Leach-Wilkinson cannula, right, you take control of the cervix, inject whatever device is there, whether it is Leach-Wilkinson or whether it is catheter. Inflate the balloon. If the catheter is there, just make sure that everything is secure, right? Then you start injecting water soluble contrast. So it is very important. Usually 10 centimeter to 10 millimeter milliliter to 15 milliliter would be good enough, right? And but if there is some abnormality, like if hydrosalpinx is there, some other abnormality is there, if the endometrial cavity is enlarged, so you may need more amount of contrast, but usually 10 to 15 ml of 300 or 350 milligram of iodine, that would be sufficient. Important thing is that you need to inject the contrast slowly under floor, right? In the initial stages, small filling defect would be picked up. Okay, so slowly you fill up, look for if there are any filling defect, and gradually you start injecting till the entire uterine cavity is outlined. Then you can have a look at the outlines of the cavity, and as you inject more, the tubes will start filling in. All right, tubes will start filling in, and gradually you would see filling of the entire tube, and in a normal case this contrast would then spill out into the peritoneal cavity. So once again, to emphasize, inject slowly. Number one, look out for, in the early phase of the investigation, look out for any filling defects. Okay, and then wait for the cavity to distend, then the tube will fill, and then there'll be spillage. So if you are able to see the tubes well, you are able to see the spillage on both sides, immediately stop. So once the tubal spillage is seen, so that means the purpose of the study is complete on both sides, right? So you don't inject more. All right, so 4 spots radiograph are taken following scout film. As I said, early filling phase for filling defect in contour, then for the uterine cavity. Now I could just show you in the next slide. This is how it is done. This is the early phase where slight filling of cavity is there. As you inject more, you can see the cavity gets outlined very nicely, and the tubes have started filling in on both sides, right? As we inject more, the tubes are now completely outlined, and later on you would see that spillage of contrast into the peritoneal cavity. This is the time to stop the investigation. Our purpose is achieved. What we need to document is, we need to document this early phase to show that there is no filling defect, because when this is completely filled, this small filling defect may be obscured. Then we need to document this to see the shape of the uterine cavity, the contour of the uterine cavity. Okay, then we need to take views for the tube. If it is not seen properly on a AP view, you may do a oblique view also to outline the tube completely, and then you take this view after the spillage has occurred. So how do you know that this is a normal spill? Because sometimes restricted spill may also occur. So if it is a normal spill, this contrast, immediately will rush upward, right? So it will it will go towards the right paracolic space, it will go towards the left paracolic space, and then you would see that contrast is outlining the bowel loops. You will see those filling defects of produced by the bowel loop, okay? And the contrast would freely flow into the paracolic spaces. So it's a normal spill. There is no chance of any restricted spill happening, okay? So once you have done that, and as I said, if you need to visualize the tube nicely, sometime if here, for example, if this tube is getting obscured and you need to see it well, take an oblique view. So usually 4 views are enough. Usually more than 6 are not required. And very important thing, if you're doing it under fluoro, always do a limited fluoro. So what you do, this thing, see under fluoro, take an image, see this part, take an image, see this part, take an image, and like that. So you would be giving minimum radiation to the patient. All right, so this is an image of the normal HSG. So what do we see is, we look at the endometrial cavity. The outline should be very smooth. It is a kind of triangle with the apex, or a pyramid with the apex facing down and the base facing up. All right, and the outline would normally be smooth, and you can see the tubes very well. The tube has 4 parts. This part is the interstitial part. Then we have this isthmic long isthmic segment, then a wide ampullary segment, which is the widest part of the tube, and then a small infundibular or the femoral end from where the contrast would spill into the peritoneal cavity. Okay. All right. So evaluation of uterine cavity. Yes, you can see these anomalies. I would just show you the images because detailed evaluation is these days done with the 3D USG or MR. There are various classification. I'm not going to go into that. I'm going to just show you the image of this because this is generally not the indication for HSG. You may just see it as part of your investigation of infertility. So unique coordinate uterus, how do you see it? You would just see a oblong, sort of contrast fill cavity, which communicates with one tube and which is usually deviated to one side. So this is classic unique coordinate uterus. Now bicoordinate uterus and septate uterus, they may be difficult to distinguish. Bicoordinate uterus is due to incomplete development. Now this could be bicoordinate unicollis where there is single cervix, or this could be bicollis where the two cervix is there, and it may sometimes look like septate uterus. So if you see it on laparoscopy or on HSG, the basic distinction is by looking at the uterine contour. In septate uterus, the external uterine contour is convex. Okay, where here it is kind of concave, a kind of contour is there. Now that distinction, as you know, because HSG outlines only the lumen, that is not possible on HSG, right? That is possible only on 3D ultrasound or an MR, but there are certain indication on HSG which may help you. The thing you need to remember, because that may be asked to you during the Viva, what you do is you measure the intercornual distance, right? Intercornual distance is usually more than 4 centimeter. In cases of bicoordinate uterus, it may be less or less than 4 centimeter in septate. What is more important is the angle. In cases of septate, the angle is acute, okay? Whereas in cases of bicoordinate, the angle is usually obtuse, right? So this, you remember these 2 points, the intercornual distance and the angle between the these lumen or the so-called horns, right? Then arcuate uterus is a normal variation in a way that there is just gentle indentation on the uterine fundus. The external contour again here is absolutely normal, and it may actually mimic presence of fibroid. So again, you need to see it on 3D USG on MR or MR. Just be aware of this entity. Uterine didelphys, where there is complete duplication, including that of vagina and cervix and the uterine horn. So you would see two separate structure, and you would need to cannulate both the cavities. As you can see, there are two cannulas here, and here you can see this is the one endometrial cavity, this is the other endometrial cavity, right? So this appearance is absolutely classic. Even on HSG, if you have this appearance, you can diagnose that this is uterine didelphys. Now, T-shaped uterus, this is something we do see in India as a part of infertility workup. The two major causes of T-shaped uterus is, diethyl stilbestrol therapy, post that, and then tuberculosis. Now, diethyl stilbestrol uterus, that is now past, we don't see it anymore. So, if you see this T-shaped uterus, that is most likely in India due to tuberculosis. So, just remember that. So how do we diagnose this? The cavity has a classic T configuration. You can see there is a narrowed irregular endometrial cavity, as you can see here. There is a short upper uterine segment. You can see the lower uterine segment is pretty long. The upper segment is short. There is constriction of uterus with reduced volume. The tubes are truncated and irregular, and there is widening of the interstitial and the isthmic part of the tube, if you see this. Okay. So this is classic appearance of T-tube. I'm sure you must have seen one or two T-shaped uterus till now in your practice. This is, I would not say fairly common, but it is not rare either. Now, luminal filling defects, there are various causes. Most important cause is air bubble. As I told in the beginning that you need to have that column of contrast before you inject it into the uterine cavity. But despite all precautions, sometimes the air bubble do creep in and you would see them as multiple or solitary filling defect in the contrast column in the endometrial cavity. So what do you do? How do you recognize that? One thing is that you would see that they are fairly round. They are surrounded by contrast on all sides. Once you see an appearance like that, what you do is you just keep on injecting the contrast. So as you keep on injecting the contrast, that creates pressure in the endometrial cavity, and these air bubbles, they would move inside the cavity, and ultimately most of them, they go out through the tubal end. Okay, so mobility is an important criteria. They move freely within the cavity, especially when contrast is injected. So that is how you rule that out. Then myometrial fold. So what is basically myometrial fold is that when you do the this study in the early part, early phase. So what happens? The endometrial is shed, and this myometrium starts. This projects quite frequently into the cavity. So you would see this kind of filling defect in the contrast column. All right. So just remember that the shape of the uterus is maintained, and this involves the entire wall. So how do you resolve this dilemma? Again, here you keep on injecting the contrast. As you keep injecting the contrast, this myometrium would be compressed and this defect would slowly go away. As you can see on this side, this defect is gone. On the other side, this is reduced. Okay, so that is how we um, decide that this is not a pathological thing. This is just normal myometrial fold which is producing a filling defect. Now, this is a very common appearance you see in HSG. This is basically intrauterine synecdoche, a complication of endometritis. So, what you would see is that the endometrial cavity would be irregular, which is a feature of endometritis. Okay, and then you would see some irregular area, which are just not filling up with the contrast. You are seeing filling defect in the contrast column. They have no particular shape. They may be bizarre. They may be small. They may be large. But then if you have that history of PID, history of intervention or MTP, and you see features of endometrial irregularity with these kind of filling defect, you can safely presume and report that this is basically intrauterine synecdoche, and then the hysteroscopy would be done and some treatment for this can be instituted by the gynecologist. Endometrium polyp, yes, this is seen as a very well-defined filling defect, in the contrast column. You might be able to see the stalk in some cases, and that is how you diagnose. And unlike the air bubble, they do not move much. Okay, once you see like that, you can say that this filling defect could be due to endometrial polyp. Then what you can do some sort of sonohysterography, either contrast enhanced or just plain simple senile sonohysterography, where this can be conclusively determined. Again, emphasizing the point that although HSG is sensitive in picking up intraluminal filling defect, it is not very specific to determine what could be the cause of this filling defect, and you may have to resort to other investigation to find that. Myoma, this is again seen as a relatively larger filling defect in the contrast column. You would not be able to see, you would be, because this is projecting into the lumen, especially that submucosal myoma, you would be seeing contrast on the side. Okay, so again, you determine that there is a filling defect and then investigate what could be the cause of filling defect. Here, one indication for myoma could be here the endometrial cavity as such is enlarged, which is generally seen in cases of myoma, and it is a big filling defect. All right, and it seems to be attached to the wall, so myoma is a likely possibility. Now coming on to the main work for which HSG is done, that is the evaluation of fallopian tube. So here we just see the entities one by one. So this is a very common thing which occurs with HSG because the patient is stressed, and when this contrast is injected, the tube itself may undergo the spasm, and then it may kind of simulate that this patient is having corneal and tubal block. So what do? we have two options. If we see that contrast is not going into cornu, what we can do is we can just wait for some time and ask the patient to relax and inject some more contrast and see whether it is going or not. And another thing is to inject some relaxant like buscopan or glucagon. We inject buscopan, and this is usually the practice. If we see, corneal and non-filling up, usually we give buscopan. Some people give buscopan even before starting the HSG, before injecting the contrast, so that this tubal spasm thing is ruled out. And if we see any block here, that is actually a pathological block. But this is what you can do. These are the various options. Wait, give buscopan either before procedure or during the procedure when you see this appearance. Okay, so with this buscopan, this tubal spasm should resolve. All right, so this is just, I told you that here on both sides there is this corneal end is not filling up, the dye is not going beyond that. Okay, so you just give buscopan. If it goes, fine. If it doesn't go, that means there is some abnormality. And most of the time when you see this kind of abnormality, mostly it is due to tubal spasm. So please make sure that you give buscopan in all such cases. Hydrosalpinx. Hydrosalpinx is basically due to tubal blockage. The proximal segment of the tube would dilate. So what you would see on HSG is a tortuous channel which is elongated, which is filled with contrast, and the tube is larger for size. It is very easy to diagnose. As you can see on this side, the contrast is not going out. In the proximal end, you can see the tube is widely dilated. Okay, and here in the interstitial part and the ischemic part, this is normal, and in the distal ischemic part and the ampullary part, there is dilatation. So this is classic hydrosalpinx. On this side, the tube is normal, and the contrast has come from the right side to the left side. So that is also the advantage of taking sequential X-ray. Otherwise, you might just think that this contrast has come from this end. Okay. So what we do is we see this. If that confusion is there, whether this contrast is coming from this tube or whether this tube is also there, so you do a very early film, and then you do a little later film where you can see this contrast has gone, right? And then you wait for some time. Let this contrast go. Okay, that is the last resort. Otherwise, usually if you are experienced enough, if you are doing it on a regular basis, utilizing fluoro, this kind of problem should not arise. But if this problem arises, it is always advisable that you re-inject the contrast to settle the dilemma, whether in this scenario, right? But as I said, usually that is not required. And HSG, in some cases, this is one of the advantages or things which is observed with HSG. After the HSG is done, some patient they actually they conceive after HSG. It is said that this may be because some intratubal syncytiae are there, and they get broken with the help of contrast, with the help of pressure of contrast, and the partial block that is resolved. Okay. So this is just thing which needed to be told. So another example where we have this mild dilatation of the tube and there is no spillage. And here if you see some small amount of spill is there. So this is a restricted spill. We'll come to this in our later slide. All right, here this is just to show how a dilated tube would appear on an HSG. Now this entity, Salpingitis ischemica nodosa, right? This is basically an entity where on HSG you would see that there is outpouching of contrast from the tube. Usually it would affect the ischemic segment, okay? And it is important to recognize this entity because this is usually associated with higher incidence of ectopic pregnancy. This is where you see the ischemica nodosa on both sides. And here it is unilateral, the tubal blockage is there, and you can see this contrast outpouching coming from the ischemic end. This is the classic appearance of Salpingitis ischemica nodosa. It will come to you as a spotter in your examination. Now this is another entity which is called the beaded tube. What you see is that there are alternate area of dilatation and narrowing of the tube. This entity is usually associated with tuberculosis. You can give diagnosis of tuberculosis or suggest diagnosis of tuberculosis when you see this beaded appearance of the tube. Now coming to post-tubal ligation, I told you what is the indication for that. So usually they are tied around the fimbrial end. So what you would see, you would inject the contrast, and you are not going to stop the study till you have clearly documented the entire tube till the point of this ring which is there. That has to be documented. Like here, you can see the tube is outlined very well, and then here it is stopping at the level of fallope ring. And on the other side, also we try and document the entire tube, and if that is not possible, we try and inject more contrast, but be sure that there is no contrast is not spilling out from the other side. Now in this scenario, sometimes it becomes very difficult to say that this ligation has been successful. So what you need to tell that here this blockage is clearly seen at the level of the ring, and on the other side the tubes are not well visualized, but there is no free spillage into the peritoneal cavity, suggesting that ligation is successful, right? So have that guarded kind of report when you see this kind of appearance. So here you can see on both sides, you can see the tube very nicely outlined with the contrast till the point this device is there. So you can be sure that here the ligation has been successful, that you can confidently write. Now here in this case, what you see that here is this loop here on this side, and on the other side also you can see this two device, whereas on this side there is no spill. On this side there is a free spill from the right side. So that means on this side tubal ligation has not been successful, right? So this can happen that on table the surgeon may feel the tube has been ligated successfully, and when you do the HSG you would see that this has slipped and this tube is not perfectly ligated. There is spillage of contrast, and you report that as such, and so that this procedure is redone and the tube is ligated again. Now this is another thing which is possible with the use of HSG, that is the diagnosis of peritubal disease. So what happens in cases of pelvic inflammatory disease? What can happen is that there would be thickening of the tubes, okay, due to infection in the tube, and due to infection of the peritoneum there will be peritoneal adhesions, okay. So tubal thickening and peritubal disease and peritoneal adhesions. All right, all of these can be seen and nicely visualized on HSG. So what do we see? The tubal thickening can be seen as a peritubal halo, as you see here. You can see this lucent filling defect. This is the contrast inside the lumen, and this is the contrast outside the lumen. And this tubal wall is thickened, so this is seen as a lucent area. So that means there is thickening of the tube. All right. Then restricted spill. As I told you that in cases of free spill, what happens? The contrast would come out of the fimbrial end and it would immediately rush, like you can see here on this side. Here it is rushing immediately to the upper part, and it is outlining the tubes also. But if you see here, this contrast is in form of a bizarre shape. It is bizarre shape, it is persistent here, it is not going up. So you need to take a delayed film to distinguish, between this restricted spill and the free spill. You need to take a delayed film. You may wait up to 5 to 10 minutes, or you may keep on injecting contrast. You would see that contrast is accumulating in form of a cavity at a particular place. It is not moving. Normally it should move, it doesn't move, and then if you take a film after say 2 minutes or 5 minutes, it remains there. Normally it should have moved up. Okay, like here in this case, what you can see is, you can see the tube is also thickened. You can see this peritubal halo. You can see this bizarre configuration of the contrast. good amount of contrast is accumulated here. It should have moved up. Now this particular configuration where the tubes are vertically oriented, you can see this, the tubes are vertically oriented here. On this side also the tube is vertically oriented. This usually implies that there are peritoneal adhesions, right? So if you combine this with the fact that there is this persistence of contrast, you can very well be sure that peritoneal adhesions are there, and you can report that along with the fact that there is tubal thickening. So clear evidence of chronic PID is there. In fact, in this case, you can also see there is irregularity of the fundus present, also suggesting that there is endometritis as well. All right, so this is what I was talking about. On this side, you can see this is the uterine cavity. This is the tube, right? And here there is this hydrosalpinx is there. Whereas on this side, you see that this is the tube, and you see there is this blotch of contrast. And as I inject more, it is not going. So I inject more. So as I inject more, this is just keeping on increasing, but it stays there. It doesn't go away. Okay. So that means there is peritoneal adhesion. A classic appearance where we have dilated tube, vertically oriented fallopian tube, suggesting again presence of peritoneal adhesion, and in this case there is no spillage. So this you can safely report as chronic PID with peritoneal adhesions. Here again, same, you see vertically oriented tube, you see these bizarre collection of contrast, you don't see this normally, and this is accumulating there for a long time, so you can report this as peritoneal adhesions along with the restricted spill, due to restricted spill. Now this is just in passing, we'll see abnormality of uterine contour. This is not the primary indication for HSG. As I said, during the course of infertility, while evaluating for the same, you may come across these findings. So it's good to be aware of how various abnormalities look. You can have large leiomyomas, adenomyosis, post-surgical changes of myomectomy or cesarean section. So here there is a small fundal leiomyoma. You can see this is a broad-based filling defect from the fundus, and that lucency is there. And this is a large myoma where you can see the cavity is displaced to the opposite side, and there is this big impression on the contrast column which is smooth. Okay, this is a typical picture of leiomyoma. Adenomyosis, you know, extension of the endometrium into the myometrium. So what you would expect, this particular contrast is present in the uterine cavity, and if the endometrium is going into the adenomyosis, so you will see these multiple contrast areas moving out of the endometrial cavity into the myometrium, producing this bizarre kind of appearance. This is also very, very specific for adenomyosis on HSG. Post-surgical changes, well, the myomectomy has been done, uterine cavity is enlarged, and you see this bizarre irregular filling defect. Of course, you would need the history to make that diagnosis, that this is due to post-myomectomy changes. Now, this is an appearance you would see in cases of a submucosal myoma, which has been resected laparoscopically. What you see is that there is a small area which is connecting with the endometrial cavity, and this is the area where the myoma was present. There is a residual cavity which is communicating with the endometrium. So this is how it looks, and this is the impression of the caesarean section scar. You can see this small lucent area in the lower uterine segment. This is the classic appearance of caesarean section scar. Now this is a polyp which is present in the fallopian tube in the interstitial segment. Of course, you cannot be very sure of that, and you need to investigate it again using either MR or maybe doing some kind of contrast enhanced sonography to confirm the diagnosis. The point here is that you have picked an abnormality on HSG which needs to be evaluated further. Now coming to this thing which actually happens, you would see quite frequently, the venous intravasation of contrast. It is important to recognize this entity because once you see this venous intravasation, the patient has increased risks of infection and they have to be given good amount of antibiotic coverage. So that thing you must understand. If venous intravasation is there, immediately inform the surgeon, ask him what antibiotic is to be given, and you can prescribe that antibiotic yourself. So what are the causes for that? There could be raised intrauterine pressure due to higher injection pressure, or there could be disrupted endometrium or abnormal endometrium. Now, this can be also be seen if the endometrium is infected, like in endometritis. If you do the study too early, where the endometrium formation is not complete, so venous sinuses are still open and contrast can go into that. Tuberculosis is another cause. Injury from the injury, endometrial injury due to improper placement of the catheter or the cannula, that is another cause for that. So what do you see on HSG? So what happens? You see, initially when the endometrial cavity is damaged, it is breached, and the contrast goes into the uh, subendometrial plexus. From there, it goes into the myometrial venous channel. So you would see this irregular kind of contrast, around the uterus. Okay. So you see this kind of appearance, and then you would see these peripheral veins filling up. And if a large amount of contrast injected, you can see the pelvic vein, and this will go towards the IVC. So this is the classical spotter for venous intravasation. And sometimes, as I said, this may be associated with endometritis or tuberculosis. So if you get this with a spotter, always look whether otherwise the uterine cavity is normal or not. Like in this case, otherwise the uterine cavity is normal, but because there is endometrial breach, there is the whole contrast has gone into the veins. There is no this thing, no contrast would go into the tube. So you need to abandon the procedure, number one. Number two, you need to inform the surgeon about this, that venous intravasation has occurred, and what antibiotics is to be prescribed. Okay, just remember these two things and remember this pattern. This is very, very characteristic. Okay, just a few rare abnormalities which we have seen in during the course of our practice. What you see here, that you have a tube present here, and there is this tube and the free spillage. You can see the contrast outlining the bowel. Here you can see the air in the bowel. On this side, what we can see, again the free spill is there, plus we see these two linear channels. Okay, can you appreciate? This is one and this is the other one, right? So this is the rare anomaly, that is the duplication and duplication of the tube. Now this is something very interesting case. This is the contrast being injected. What we see that this is the endometrial cavity, which is a little irregular, and then we see that this thing, this some bizarre collection is seen, which is slightly away from the uterus. So we don't know what it is. So we injected more contrast. Now with the injection of more contrast, we can see the uterine cavity nicely. But at the same time, what we see that this contrast is accumulating more and more in this cavity, and this is from here it is moving down. So this looks like, and you can see this multiple filling defect in this contrast column. Can you just guess what this could be? So I just wait for a while. You can put in your responses that Mitusha will tell me. Yes, Mitusha, any response is coming? Hello?
Sir, one has said fistula.
Yes.
A few has said fistula, enterouterine fistula.
Right. So this was a basically collouterine fistula. This tube was communicating with the sigmoid colon, and you could see the sigmoid colon getting outlined, and later on the rectum also getting filled. Okay. So these kind of complications, they can also happen in tuberculosis. This was actually a case of tuberculosis leading to this salpingo-enteric or salpingo-colic fistula in this case. Right. So this is just outlined the indications, the scope of HSG, what we can do. Only thing again important to re-emphasize that you need to be doing it in a proper way. So I would end by saying that HSG is here to stay. Its use is increasing day by day because more and more patients, because of the advanced age, they are presenting with infertility, and HSG is the screening investigation, initial investigation for determining tubal patency if we need to do some ART procedure. As I said, essential tool in infertility workup, and very important that you use a proper technique so that you don't have to repeat the investigation. Best study for fallopian tube, limited role for congenital anomalies, biometry, and extrauterine pathology. Thank you very much for your attention.
Thank you, sir, for this absolutely wonderful talk and showing us these important cases for our day-to-day practice as well as for the exams. A few questions which we can take.
Yes.
So, sir, one is that many women have wide discharge when they come for the procedure without other complaints. Should we send the patient back to the clinician and or continue with the HSG? Like, what should be done? Should it be sent back for antibiotic covers, or what is the protocol?
You need to talk to your clinician, and you need to tell that this is what is happening. And because wide discharge doesn't always mean infection, he has seen the patient, you can read out the prescription paper to him. I think this is easy thing to send the patient away. That reduces your workload. But remember, this patient has got this patient has got a date after say 3 cycles, 4 cycle. So you must try and finish the investigation in that particular setting only. So please talk to the clinician before sending the patient. Let him talk to the patient and then decide whether this patient is having infection or whether you can go ahead. Don't take that decision or involve the clinician.
Okay, sir. And should the contrast be diluted for HSG, or we should
No
not
need.
dilute the contrast?
No need to dilute contrast.
And should the cervix be pulled during procedure?
See, as I said, with these cannula, Leach, Wilkinson, and where we use the tenaculum, we can pull the cervix. But the problem with pulling is the advantage is that you can control the investigation. You can, displace the uterus. But this induces pain, and sometimes it may also induce vasovagal reaction in the patient. It is for this reason that there is increased utilization of these catheters in the HSG.
Okay, sir. And sir, any measurement criteria for hydrosalpinx?
No, not that I know. This is a very common question. For all investigations, what is the criteria for this and that? So for me, it is mainly visual. As you do more and more, you will realize what is normal or what is abnormal. Well, I did read, but did not come across any definite criteria below this or above that. You can call that this is hydrosalpinx. Or another thing is, if the other side is normal, you can sort of compare with the other side. Number two, if you can compare with the adjacent segment, the rule of thumb is if the dilatation of that particular segment is more than 1.5 times than the normal caliber, that then you can say that the segment is dilated. So these are some of the indicators.
Thank you, sir. And sir, just absolute contraindications for the HSG procedure.
Yes, absolute contraindication is pregnancy, active infection. These are the two absolute contraindications.
I think, sir, most of the questions we have covered. So once again, thank you for taking this important topic, and stay tuned because there are many more topics we'll be taking for us. So
Thank you very
now,
much.
yeah, thank you, sir. So we have our next speaker, Dr. Sanjay Yadav, sir. He is again someone who does not require any introduction, specifically amongst the exam going residents, those who are preparing for any of the exams, be it your DNBs, MDs, or be it your FRCR exams. And sir is always keen to teach. He takes out time from his busy schedule and creates beautiful spotters, share on the various social media platforms as well. So we are really thankful for all his times and effort. And sir is assistant professor at Mysore Medical College and Research Institute. He has various publications to his credits. Thank you, sir, for this academic inclination because it's of benefit to all of us. And over to you.
Thank you, Nitusha. Am I audible?
Yes, sir.
Fine. So I sincerely thank. I think you can stop your screen sharing. Yeah. Thank
Yes,
you.
yes.
So I sincerely thank Dr. Sanjeev Manesya for motivating me to again come back and take the conventional touch topic. Very few these days, like students are interested to learn or like to listen to conventional radiology. They are more fascinated towards CT and MRI. So, but still, till you get your MD degree or your DNB degree, including FRCR, they will definitely have conventional radiology images as well as cases. So don't neglect till you get your post-graduation degree. Once you get your degree, you have the choice to choose your subspecialty, what you want to do. But till you get your degree, you have to know this, right? So I just want all the residents to sit back, relax, because I was just listening to the previous class. Maybe many students are writing questions, asking doubts, all those things. First, try to listen to the speaker always. I don't want you people to take any screenshots or do video recording or all those things and waste your time. First thing is my presentation for today's talk. I'll be sharing it. I'll be giving it to the organizers. Each and everyone who registered for this conference will get my presentation. So in case you have missed something, you have not listened correctly, or you could not write down or see the image correctly, you can always go back, read the presentation very neatly and simplified form of given the images with the description, the procedure, including the reporting checklist and the format which you need to know while reporting. So that will be helpful, right? Next, coming to this image, every class I put this image because students don't like to study the conventional. Yes, they do study, but when it comes to conventions, here who's going to study this? It's so difficult. They are not interested much, I say. But at least an exam point of view, patient concern, you have to know the conventional procedures. As Dr. Lalanja said, do not deny any case. It's so important. I see many residents like they're so tired and exhausted. We try to push off the case. If they come tomorrow or come next week, this is not correct, that is not correct. Rather than doing those things, try to talk to the clinician first. What do they want? What are they expecting in our reporting in the procedure? Very important, especially for a retrograde urethrophy or a mixed cyst urethrogram, to always speak with the urologist or a pediatric surgeon when they send for MCU. Why a urologist? Because even I have made mistakes. Like suppose we're suspecting a stricture and it was when we have not done the procedure correctly, we are bound to commit mistake while reporting. And when they do surgery or they go for post the patient surgery, when they do cystoscopy, and they can pass the scope easily, then tell there is no stricture at all. So that's why it's very important to always talk to the clinician, what are the suspecting clinically, what are the indications why they have sent this procedure, and then report it. If you still have any doubt after the procedure, talk to the clinician. You have to speak. Patients will not understand what you're reporting, what are you doing, nothing. Patient wants only treatment, they want to get well and get out of the hospital as soon as possible. It is the radiologist who will be assessed only by the clinicians what we report, and the follow-up is so important. Try to do follow-up of each and every procedure what you do, so that you will get to know where we are making mistake and where we are improvising. And I don't want any of you to write anything or like do anything. Just sit back, listen. So once you go to movie, don't write anything. Now you sit back in a pushback chair, listen first. That is more important because you'll get the presentation. In case you slept also, it's late night, that too on a Saturday weekend at 9:30 to listen to a conventional. It's so boring and so difficult. It's the most toughest job to sit and listen to a conventional radiology class on a weekend. Fine. I'll be very brief and very simple. You don't have to worry, right? So I'll just tell briefly about the procedure. So retrograde mainly it is used to done, this procedure is done to study the urethral and the periurethral imaging in men, mainly for any structure evaluation or injuries or fistulas, mainly for the anterior urethra. Okay. So before starting exactly, so male urethra is mainly 18 to 20 centimeter long. You need to know the parts of the urethra. Very important. The prostatic urethra, the membranous urethra from the post urethra. The anterior urethra is mainly formed by the bulbar and the penile part. Why this is important? Because when you're doing the procedure, you need to inject the contrast. You need to know where exactly structure. To know the structure, you need to know the anatomy of the urethra. Okay. Coming to the next slide. The female urethra mainly is around 4 centimeter length and 6 mm in diameter. It corresponds to the upper part of the prostatic urethra, runs downwards and then forward embedded into the anterior wall of the vagina. Very uncommon. We don't do usually most of the retrograde urethrogram in a female. It is usually commonly done in case of males. Females, since the urethral length is very small, usually a mid-chorion cystourethrogram is done to better delineate pathology. Okay, this is just a graphic representation showing how a female urethra will be seen in an image before you do the procedure. Okay, so coming to indications, most important for urethrogram and mixed cystourethrogram, hardly there will be any practical based questions. In the practical, you will always keep this image in form of spotter, or sometimes they may keep in a film reading session asking you to identify the procedure, name 2 indications and name 2 contraindications. Any procedure, let it be barium or IVU or a HSG or a RG or MCU, you should know indications, contraindications. Don't go to practical hall without reading indications and contraindications. They will ask about conventional procedures, right? So common indications are suspecting stricture or urethral trauma or fistula or any congenital abnormalities or some prostatic abscess. Contraindications are acute UTI or a recent instrumentation or they have done some procedure, which is usually contraindicated. Okay, so before doing the procedure, okay, most important, you have to take a informed consent. I would recommend always to take a fingerprint also, because these days we don't know patient size is not a signature, they didn't explain the procedure correctly, they do a video consent and all for the complicated procedures like a cath lab procedures and all. But since this is like a daycare procedure, you don't require anesthesia, just a written informed consent will be sufficient. At the end of the PPT, I would share the consent form also. You can go through the consent form, right? And then you get in the contrast media. Usually the urographin is a recommended contrast. So you have to know what does urographin contain. the examiner's very favorite question. The moment you say, yeah, how many RGUs have done, if they ask you, might tell them 15, 20 I've done in my post-graduation course. So what is the contrast used? Whereas ionic contrast or non-ionic contrast would ask. Urographin is an ionic contrast, whereas IPM is non-ionic. So urographin contains sodium diatrozoate and meglumine diatrozoate. So both the contents you have to know. Okay. Then the coming back to the equipment, usually more important you require fluoroscopy. Sometimes in case in a department don't have fluoroscopy, you can do in a simple 300 mA or a 500 mA X-ray plant also, but it will be like blind. Fluoroscope, sometimes you can see how you're injecting the contrast and then take a spot film. But for the fixed radiography, we don't have fluoroscopy. You have to be quick enough and ask the technician to take the X-ray on time. Otherwise, you might miss. Okay. So the instruments required usually be a Foley's catheter or infant feeding tube, syringe, gloves, and iodine safety precautions. So usually, main preparations, patients asked to mature prior to the procedure. And most important, you need to dress correctly. You have to wear proper your lead aprons, your lead, whatever lead thyroid shield, even a head cap you have, and everything. Proper protection is important for you as well as the patient. Patient sometimes quite difficult because you are exposing his private part. Can't use a gonad shield, but at least the upper part of the abdomen you can use a lead apron even for the patient. Okay, please take the radiation risk, very important. You have to take care for yourself and including the patient. Coming to the technique, so how a patient is being positioned for the retrograde radiography. So usually first you're going to take a plain radiograph or unenhanced radiograph. Why? To look for any calcifications there or any abnormalities there or what is happening before the contrast is being injected to the patient. So first thing is always a plain radiograph is taken. Then the patient is made to like supine and then is treated with the legs position as shown in the image. This is how the patient is being positioned. And the aseptic precautions, you want to insert the Foley's catheter into the urethra after applying a lignocaine jelly. Do not directly insert the Foley's catheter infant feeding tube blindly. It will pain to the patient. Please take extra care. Apply lignocaine jelly and then you're going to insert the Foley's catheter or the infant feeding tube. I would recommend to use infant feeding tube to better inject the contrast will be much easier. So we use always infant feeding tube. Okay. Then you need to apply before applying the you need to load the contrast. So around 10 cc of contrast. Sometimes we do dilute, sometimes they don't dilute. I think dilution is required. 10 cc of contrast or 10 cc of normal saline you can dilute. And then apply pressure of the gland spinous to provide expulsion of the catheter or reverse flow of the contrast. And then contrast must inject slowly under fluoroscopic control. If you don't have fluoroscopy, you can ask the technician to take the direct radiograph. So first radiograph is taken without before injecting the contrast, then a 30 degree the right anterior oblique, and a 30 degree left anterior oblique. Two views you're going to take to correctly demonstrate the full length of the urethra, that is the anterior and the posterior part of the urethra. Common complications include sometimes very rarely we see a contrast reaction in case you're not maintaining aseptic precautions while doing the procedure might cause a UTI or urethral trauma if too much pressure is applied while injecting the contrast, and sometimes there might be an intravascular contrast due to use excessive pressure to relieve the structure. Okay. So coming to image interpretation. So for RGU, if the contrast injected properly, you should be able to demonstrate the anterior and the posterior urethra, and it will be filled with the contrast as you inject the contrast. So mainly the proximal membranous urethra and the constitutes the distal end of the verumentum marks the proximal bound of the membranous urethra and constitutes urethra that passes through the urogenital diaphragm. So rather than this, I would show the image. This makes it very simple. Okay. So this is the pre-contrast anterior posterior film radiograph. That is the pelvic radiograph what you have taken. This is the right anterior oblique at 30 degree, injecting the contrast, and this is the left anterior oblique you have taken the second radiograph. Very important. So when you have loaded 10 cc of contrast, when you push 5 cc of contrast, you're going to ask the patient or the technician to take the first radiograph. And before inject the 5 cc, ask the patient turn around and then inject on a 5 cc in the left anterior oblique. Okay, this is a complete normal things to make you understand the anatomy when you start seeing the retrograde urethrum radiograph. So this is the penile urethra, this is the bulbar urethra, the membranous urethra, and the prostatic urethra. The contrast seen filling into the urinary bladder. Okay. So I come to the common variants before I come to the pathologies exactly as such. Okay. So you see the first image, the contrast neatly filling in the anterior urethra, the bulbar membranes and prostatic urethra, and the contrast is entering into the urinary bladder. So sometimes you might see small extravasated type of contrast noted in here. It is the normal opposite corpus duct. Do not confuse it with the extravasation. Very important. Most of the times it confuses some extravasation we give. It's not extravasation, it is a opacified copper duct. And then you have here is an opacified little glands. Do not confuse this for the some what you call diverticulae or anything or urethritis like that. You're seeing a neat filling of the contrast, but few small outpouchings are there. This is the opacified little glands, which are the normal things. Okay. Sometimes you might see the contrast reflex on the prostate duct. So don't confuse this prostate duct reflex as a extravasation or intravasation of the contrast into the veins. Okay. So this is a bad technique. What is a bad technique? When you're injecting the contrast, be very careful. Before you inject when you load the contrast in a syringe, you're not supposed to inject any air bubbles. Means when you load the contrast, you see to that in the syringe doesn't have any air bubbles. Discard all the air bubbles and only the contrast must be injected. Do not inject air bubbles. This is a very bad technique. It shows they have not done the procedure correctly, right? So initially it will be a little difficult. So once you start practicing to load the contrast correctly, you will definitely not have any air bubbles. Okay. Next, this is again an improper technique. They have not holding the, you have to pull the glans penis and make the penile urethra as elongate as possible and not allowed to be like this. So if you don't pull the glans penis and hold the complete length of the penile urethra, there will be like a deformed shape of urethra you'll be seeing. So this is the incorrect patient position as well as their patient handling. They're very important to correctly hold the glans penis and pull the penile urethra to correctly demonstrate the pathology if there is any stricture or stenosis of the anterior or the posterior urethra. Okay, the main I've mentioned here, each and every image I've given the important findings. Okay, next. So this is exactly the common pathology what you have seen. There are like multiple strictures in anterior urethra. You can see the previous image you see. This is a normal filling. The caliber and the lumen of the length of the urethra, you are not seeing any stenosis or narrowing throughout the anterior urethra. Now coming back to this image, if you see, there are multiple stenosis. There's mild stenosis there, and then again it's dilated, and again it is stenosed on this segment, again it's dilated over here. So this is a consequence of a panurethral urethritis. Sorry. And down you can see over here, there is filling in the Cowper's duct. This is not extravasation. Okay. Next image. So as a case of a gonococcal urethritis, you can see the stricture in the anterior urethra, but do not directly give in a reporting as a gonococcal urethritis. You need to mention there is stricture in the penile urethra, probably features suggestive of query, gonococcal, or most likely a gonococcal urethritis you can mention. Sorry. And then this. The stricture in the membranous urethra. Sorry. So this is the, they've done both the studies. Whenever you're demonstrating a structure or suspecting a structure or complete stenosis of a urethra, you need to demonstrate both. Demonstrate both means what? Both the anterior urethrophy as well as the retrograde urethrophy. So this is a retrograde urethrophy. You're seeing there is a complete structure near the prostatic part of the urethra, and then you are doing a mixture in cystourethrogram. The bladder is completely filled with the contrast, and the patient is asked to what urine, and you can see there is complete stricture formation at the prostatic urethra. How do you identify here? There's a wide opening at the bladder. Okay. Next, this is a descending ureterogram showing the long segment penile structure. So you're not able to inject contrast. Imagine the patient meatus external opening is completely stenosed. You're not able to inject the contrast. You would ask that you would fill the urinary bladder with the contrast and then ask the patient to void the urine. So once the patient is voiding urine, you can see there is filling of the prostatic urethra, the membranous and the bulbar, and it comes forward. It's complete narrowing the long segment penile structure. Again, there's a long segment bulbar structure. So the long segment structure suggests urethroplasty is a likely surgical intervention. Probably they've done a surgical intervention, and then after urethroplasty, they would send again for the retrograde urethropy to demonstrate the structure. Or if there is any complete narrowing or the structure has resolved, they do so. There's a small outpouching over here. You see, this is a urethral diverticulum. Sorry. This is a urethral diverticulum. So sometimes you have to mention other pathologies when you see not only the stenosis or a structure, you might see a diverticulum, you might see an intravasation or extravasation. Okay. And this, sometimes they do get a film like this in exam where we don't know what exactly is happening in the image. First thing is need to identify the procedure. So they might ask what are these multiple radiodense opacities noted over here. These radiodense opacities are the brachytherapy seeds implanted in the prostate for some prostate malignancy or anything. So sometimes the patient undergone a post-radiotherapy, so there might be some structure. So there's a post-brachytherapy radiotherapy, severe structure of the prostatic urethra. So they're done a mixed cystothelium where the bladder is filled with the contrast and the patient is asked to avoid urine. So it's not a very, very thin stream of contrast seen passing through, which indicates there is a stricture. So again, the retrograde, there is a contrast intravasation, very important. I was telling always there is contrast intravasation. So you can see the contrast filling through the dorsal vein of the penis. It's a very important image. Why? Because sometimes there will be complications. You have to be very careful. There's a contrast intravasation. Extravasation means it will be just next adjacent urethra, it will line in the corpus spongiosum muscle. Usually the extravasation occurs. So intravasation is going into the veins. It will be very careful, especially systematic veins. The patient might develop a allergic reaction for the contrast. Okay, and then when there is a forceful injection of contrast material in doing the procedure, when there is suspect of structure or chronic inflammation, there will be a reflex of the contrast into the veins. So you see the first image, the reflex of the contrast into the veins, the corpus spongium. So you can see the contrast clearly going into the veins. The next, again, the RGU procedure, you can clearly see there is the intravasation of the contrast into the veins on the both the images. There is a complete structure and narrow the bulbar urethra, and then when you put more pressure to inject the contrast to push the contrast into the bladder, you can see when the excess pressure, the contrast has gone into the veins. Okay, this is the contrast reflection of the seminal vesicles. Very rarely we see the contrast reflection of seminal vesicles in a vas deferens, but we should know this entity and not get confused with the contrast intravasation into the veins. So commonest cause for urethral stenosis or stricture inflammatory will be a gonococcal, that is infectious urethritis, or other causes includes balanitis xerotica obliterans. Post-traumatic will be a pelvic trauma or instrumentation. Sometimes there will be congenital causes. You should know the commonest causes for the stenosis or structure. In India, you have to also suspect sometimes even tuberculosis, which is the most commonest cause. You might see a beaded appearance of the urethra. So the commonest cause for under these settings you need to write. Okay. Coming to the MCU procedure, the mixed cystothelium. So they will ask you the indications. Usually it is common done in children, mainly to look for the UTI. There's a reflux, the voiding difficulties, mainly to look for vesicular reflux. And then in adults, mainly to look for the level of the structure in the urethra in a male patient, especially sometimes you are not able to push the contrast from the anterurethra. You would do a mixed cystothelium to look at the level of the obstruction or the stricture formation, or sometimes suspecting a vesicovaginal fistula or suspecting a bladder urethral trauma or urethral diverticle. Again, the contrast use. So contraindications are acute urinary tract infection. So usually a low osmotic contrast medium such as iopamidol or other contrast use. So equipment mainly includes a fluoroscopy, because you need to see in the fluoroscopy whether the bladder is getting full. If you don't have fluoroscopy unit, you need to ask the patient whether they're feeling the fullness in the bladder. So most of the time when the patient comes to you, usually they would have a suprapubic catheter inserted. So you have to dilute the contrast with a normal saline and then inject the contrast into the through the Foley's bulb into the urinary bladder, and then see through the fluoro whether the bladder is full. If you don't have fluoroscopy machine, then you need to ask the patient whether the patient is feeling fullness to pass urine. Okay, and then the patient preparation usually mean as usual for both the procedures. You need to ask the patient to micture it prior to examination. So this is the procedure how it is being done. So under aseptic precaution, they catheterize urinary bladder. In case the external anterior urethra or the glans meatus is closed, you have to insert the catheterized medium for the suprapubic route. So you need to insert the contrast medium slowly under fluoroscopic guidance to see the filling is there. And then the patient is asked to inform when he has the urge to mixture it. So once I ask the patient to mixture it in urine receiver as an erect oblique position, very important, the patient has to stand under the oblique position. So spot images are taken during mixturation in right and left oblique. Very important, the right and left oblique projections. A full length view of the abdomen is taken to demonstrate undetected reflex of the contrast medium. Once you take the right and left oblique, you're going to take a complete supine radiograph of the full length, including the kidneys, to see if there are any reflex. Okay. Complication as usual, both the things, they will have a contrast induced reaction sometimes if it goes into the intravascular of the vessels. And the contrast in cystitis, or UTI, catheter trauma, or bladder perforation, have to be very careful with the overflowing of the contrast and retention of the Foley's catheter. So after care, patient should be warned of some rare dysuria or retention of urine. In case of reflux, antibiotics are to be prescribed. So this is the mixed-in cystourethrogram image where the patient of the contrast in the urinary bladder, patient is asked to void urine. You can see the normal anatomical structures. This is a male and this is a female where the mixed cystourethrogram or a normal voiding urethroplasty is performed. This is a complete opacification of the urinary bladder. Then we have the prostatic urethra, the membranous urethra, bulbar urethra, and the anterior penile urethra. You can see the complete filling and the contrast being passed and the female. Okay, and then coming to the common three projections which I used. This is the mainly the there is a stricture when this the left antral oblique and the right antral oblique is taken. The patient is asked to void urine, and you can see there is a stricture, the penile at the right section on the membranous part of the urethra. However, the penile urethra appears normal in caliber. Okay, so this part you can see this is the urinary bladder, this is the prostatic urethra, and then you have the membranous urethra where there is a complete stricture. The patient is not able to, the contrast is not being passed, the lumen is completely reduced as compared to the prostatic urethra over here. Okay, so the commonest indications like clinical signs that suggest urethral injury, other commonest indications where you want to do a mixed cystourethrogram. Usually in a trauma injury, when you suspect a bladder injury or when I suspect a urethral injury. So usually when they examine a rectal examination after pelvic fracture or a perineal trauma without a fracture. So and in the females, there will be a vaginal bleeding or a voiding difficulty or blood at the meatus or hematuria and urinary leak per rectum. These are the commonest indications of a urethral injury for mixed cystourethrogram. This classification of bleeding and all these things, usually they require more for theory, very unlikely to ask in a practical thing. But when you start reporting also in the day-to-day routine practice, it will more of you be describing where exactly the urethral structure is or exactly the stenosis is, what has happened. Nobody will ask you to grade or state something like this, but just for theoretical purpose, since it is there, we are giving. Okay, so type 1. So from this is a mixed cystourethrogram where the male patient with a pelvic fracture trauma shows the posterior urethra which appears stretched but intact. It is only stretched but intact. This is a type 1 injury with no evidence of contrast material extravasation. Okay. Type 2. So from the sudden urethrography, it shows an area of contrast metal extravasation indicated of injury to the posterior urethra with an intact urethral diaphragm. These one is indicate type 2. Okay. Mainly type 2, what has happened? Contrast material extravasation, which indicates an injury to the posterior urethra. Injury to posterior urethra with contrast metal extravasation is called as type 2. In type 3, there will be a pubic bone fractures, will be complete posterior urethral resection. There will be complete tear through the urethral diaphragm to the anterior urethra with resultant extraparietal contrast metal extravasation. This is type 3. Type 4. So there will be a complete transaction of posterior with a contrast mixture into the perineal soft tissues as well as bladder neck disruption. In type 4, there will be involvement of the bladder neck also. Okay. In type 4A, will be extraperitoneal contrast metal, will be extravasation extending from the bladder neck injury around the proximal urethra. It is indicated type 4A injury. Type 5, they will like initial complete transaction of both the anterior urethra, but does not allow the estimation of length of it. Only the anterior urethra will be involved. Okay. So there's one more complete type 5 as a complete resection of the anterior urethra. So this is a very important image. Usually most of the exams, they do keep this radiograph and ask the student what is the procedure and identify the procedure when tell the findings. So don't tell this an IVU. The moment you see the radiograph, you have to be very, very careful. Give a pause of 5 to 10 seconds. See the image correctly first. Where is the contrast entering? How it is going? You can see from the bladder, the contrast is going outside over here to the posterior membranous, posterior part of the urethra and all. So usually IVU, you don't ask the patient to mixture it. Only in a case of mixture in cystourethrogram, you ask the patient to mixture it. So that's how the urine is going out. And due to the reflex, the contrast seen entering into the ureter as well as it entering into the bilateral pelvic ileal system. So this is a classical case of a grade 5 reflux, where this reflux in the collecting system as well as severe dilatation. Okay, this reflux of bleeding you have to know this grade 1, 2, 3, 4, 5. Okay, and then this is a common cystogram. Very common. This radiograph will always be kept in a spotter and our film reading session, where the moment you see this radiograph, first thing they're going to ask is identify the procedure. The procedure is obviously the first image is the contrast completely filled. The patient is being asked to void. You can see the contrast entering into the posterior part of the urethra. Okay, so is a mixed-rating cystourethrogram procedure, you can see multiple diverticulae or pine-shaped urinary bladder. It's a classical case. Okay, so what are the causes for this? They might ask you for a pine-shaped or a Christmas tree pattern of a urinary bladder includes a congenital myelomeningocele, a trauma or infection, or some operations the patient has undergone. Okay. No. So coming to a summary, so retrograde urethrocystography is mainly done to assess the anterior urethra and the posterior urethra and to know if there's any stricture, stenosis or urethritis. These are three commonest things, indications to do a retrograde urethrocystography. Then cystography is mainly done to evaluate any bladder pathology, to look for any bladder diverticulae or any bladder outpouchings or cystitis. They are going to do a cystography. And avoiding cystourethropy mainly to look for the reflex, common in pediatric age, look for UTI infection and to see if there is the exact height level of obstruction in a posterior urethra. In case you're not able to inject the contrast from the meatus from the anterior urethra to know the site of obstruction or stricture formation, you want to do a avoiding cystourethropy. Just a repeat of these things. And the technique at presentation, usually a standard urethropy should be performed to evaluate both anterior and the posterior urethra. See, both are supposed to do if there is any stricture or narrowing or stenosis. Most of the time, what we do, the urologist send for RGO, we inject the contrast. Contrast is seen passing smoothly to anterior urethra and the bulbar urethra. Membranous urethra, the contrast not seen entering and with the stricture. But actually, you are supposed to do a mixed cystourethrogram also and ask the patient to ward the urine and see where exactly till the patient is able the contrast being passed. We just not stop at RGU and give up the report. The complete study involves both the retrograde as well as the anterior studies. Okay. So this is a systematic report, how you need to mention in a standardized report in a day-to-day practice when you are reporting retrograde urethrophy and a mixed-rating cystourethrogram. You need to mention how was the study done, by injecting which contrast was injected, whether ionic contrast or non-ionic contrast, infinite tube was used or a police catheter was used. After injection of contrast, which portion of the penile urethra was visible? Only the anterior part was visible, or the contrast was seen in the posterior urethra as well as the urinary bladder. All the three entities has to be mentioned. Just don't write like only anterior part was visualized. If the posterior part is not visualized, you have to mention the posterior part of the urethra was not demonstrated. And then how was the injection injected in the high pressure, and need to mention how the contrast does not go beyond the point of stenosis. So the remaining anterior urethra or the posterior is not visualized. So then we're going to do urinary bladder was distended with the diluted contrast. So dynamic uretrogram was done, and then through the infant feeding tube and the patient attempted to mixture it. However, the posterior urethra, the remaining part of the anterior urethra was not visible based on where the exact level of stenosis. So you're going to impression as only the penile urethra is visualized, which part of the penile urethra anterior. The thigh structure at around 13 cm from the meatus. So rest of the anterior posterior, what was not visual, I need to mention. Okay. So with this, I would like to end and is a short class. Don't expect too many things from RGU or mixed cystourethrogram. You have only three things in RGU. First thing is they'll ask you always structure or stenosis. Most important is whenever you're giving a structure, see to that you have done the procedure correctly. I have made mistakes where we don't inject the contrast with full pressure. Obviously, the contrast will not go beyond the posterior urethra. The contrast will not enter the bladder. It will give a false opinion of like a stricture formation. It will sometimes when the patient is very anxious or stressed out, even for spasm also, the contrast will stop at the posterior urethra, it will not go beyond. So always talk to the urologist what they're expecting clinically, and what is suspecting clinically. The suspecting stricture or stenosis, did they do a cystoscopy, what are the clinical findings, they correlate with your RGU procedure. Okay. And then cystogram or bladder pathology and avoiding meant to look for the reflex or exactly the pinpoint the level of the stenosis or stricture formation. Right? With this, I would like to thank the organizers for giving me an opportunity to discuss about the conventional radiography on a Saturday late night evening. So you will get the presentation in case you have missed that class, you could not attend due to some problem, whatever. Always go to the presentation. I think that has got almost all the pathologies of anterior or retrograde orthography as well as the mixed rating cystourethropy. Thank you.
Thank you, sir.
Yeah.
There are a few questions.
Yeah.
We can take a few.
Yeah.
One is how to differentiate whether stricture is at the bulbar or membranous part of the urethra in film. Sometimes it get confusing.
Correct. I think the anatomical part, landmarks, if you see, this will be much more easier to identify. So sometimes it not be, we may not be able to exactly pinpoint the division on a film. Prosthetic urethra, yes, you can identify. The membranous part and the bulbar part are very small, narrow segment. To pinpoint are quite difficult because we don't measure anything like on 13 centimeter or this length or this. So we can just mention the structure as noted at the bulbar part or membranous or the junction of the membranous and the bulbar part. I'm not sure exactly where, how to measure exactly how distance. No, none of the books have mentioned the distance criteria from the urinary bladder or from the anterior urethra. Approximately they say around 13 centimeter, but we don't measure in the console or anything like that. Probably this image, just go back.
Then radiologically, how to differentiate spasm and stricture in
This is this is very important. Recently also even I have made mistakes while reporting spasm and stricture. First thing is you need to always take the patient to confidence. If the patient is not calm and stressed out, obviously they always get a picture of spasm. So sometimes we have to repeat the procedure or talk to the clinician whether the cystoscopy, whether able to pass the scope. Stricture, it will be like a smooth tapering, means it's like a sudden abrupt tapering will be there. Whereas probably I will include the images in the PPT when I share the students. This image, I'll come back to one image. Yeah, you can see this image. This image, you can see there is smooth narrowing, the contrast not being passed over here. How much? If you put correct pressure and correct positioning is there, if there is a spasm, it will get relieved. But if the stricture is there, the contrast will not be able to pass. It will be like abrupt stoppage of the contrast. Beyond that, we will not be able to visualize the contrast. That is a clear case of stricture. As a spasm, maybe when you're going to take a left oblique position, you're going to change the patient position and make him the conference, spasm might relieve. But sometimes we have seen cases where we are given a stricture, and when the patient is taken to OT because of stricture, they could pass the scope easily. So it has come as a normal spasm. So first thing is taking the patient to confidence. Second thing is applying the lignocaine gel correctly. If you're not causing any pain to the patient, there won't be any spasm. If you police catheter, usually there will be a chance of spasm. So sometimes you have to repeat the procedure or talk to the urologist. In top findings, it was a stricture, stricture or a spasm.
If both RGU and MCU are advised, which one should one go for first and why?
Correct. Very important. If both RGU and MCU are advised, first look for the indication, whether it's adult patient or a pediatric case group, what is the indication? So they're suspecting a stricture or stenosis or a UTI or a reflux, then you're supposed to do a MCU first. If you're suspecting only a stricture of the anterior posterior urethra, so you can always do a RGU first and then look for the site of stricture or a stenosis and then do a MCU to exactly pinpoint the level of narrowing or the structure or the stenosis from the posterior urethra. If you're suspecting structure, first do RGO. If you're suspecting UTI and you want to see for reflux, do a MC.
Yes, sir. Thank you for that. And also, they are asking if there are any practical tips, because in pediatric age group, it is difficult for the patient to ask the patient to micturate on command while performing MC.
Yeah. Definitely. So it's quite difficult. Usually it takes a lot of effort. You need to talk to the patient parents, take them into a conference, motivate, and little training is required. To normally ask them to avoid urine also they won't avoid. So usually we fill the bladder more. Once the bladder is full more, they will not be able to control it and they will definitely avoid the urine. If you fill the bladder only partially, probably 150 or 160 cc, they may not avoid immediately saying that I'm not able to avoid, urine is not coming out, they may say. Once you fill the bladder more, obviously they have to void. The bladder reflex will start. So they would void if the bladder is filled a little more, but doesn't mean you have to fill too much more. There may be chances of other injuries to the bladder. So fill at least around 250 cc of the contrast so that the patient will start having a feeling of sense to void. And parents, very important, they have to be there always when the pediatric age group are doing. So the patients are like comfortable and they would follow the instructions. It's an art actually. They need to talk to the pediatric patients and take them into confidence.
And sir, just I think this is specifically for the Vivas. They want you to clarify the LAO and RAO.
Okay.
Technicality as patient is supine.
Okay. you need, I've given an image also in this over here, where you're going to position the patient. I think I have to add few more images, how exactly the patient is positioned, the flexion of the knee joint, and then he is asked to rotate 30-degree, and then the cube. I think there's a positioning book, Merrill's and Clark's. It's very neatly given. I'll include that image and then send it across. Here I've just mentioned 30-degree right anterior oblique and 30-degree left anterior oblique. In exam, I might ask you, where's the tube centering, where exactly the tube centering is being done, how much is the collimation being done, exposure, and then they ask. I'll add those things and send in the presentation.
Sure, sir. And how early can we perform RGU following trauma to the perineum?
Immediately, you can do immediately. There's no contraindication exactly, because the RGO is mainly done to look for during stricture or any trauma. When there is a trauma, you're suspecting a urethral rupture, urethral injury, you can immediately do. It will not cause any problem. You can use a low osmolar contrast, even if there is intravascular contrast to veins, nothing will happen. You can do it immediately.
I think most of the questions we have taken. So
Yeah.
thank you once again, sir, for your
Thank you so
time
much.
and effort.
Yeah. Okay. Thank you, everyone. Yeah, just before I summarize, so I will send the presentation with few images where few students have asked how to differentiate between stenosis and spasm. Second thing is regarding positioning, that is the tube factors, how much KV, how much MES, what is the collimation, and how the patient is in positional guidance in that presentation.
Sure, sir.
Yeah.
So we'll be sharing those presentation with all of you. And now let's move ahead to the next talk by Dr. Upreti sir on yet another important topics, and that will be followed by the spotters. Upreti sir, over to you. Sir, you are on mute.
Hello.
Yes, sir. Yeah, yes, sir. You're audible.
Okay, so my screen is also visible.
Yes, sir.
So I want this talk to be interactive, because for clarifying the concepts and all, I need to understand that everybody is understood. So whenever I ask the question, whatever responses are coming on the chat box, kindly let me know. Okay.
Yes.
So this is talk on barium studies, disease pattern recognition. So barium is actually, if you get barium as part of your case, what is going to happen that initially you are going to be quizzed on barium study also, and as an examiner for past about 15 or 16 years, these are the problem area which I have seen, which may happen, which usually actually happen with when the barium studies are part of the case. So many times candidates are not able to identify the study properly. Actually, this might look strange, but it actually happens. Then there is a confusion about what is weight by volume, what is weight by weight, what are the indication for double contrast, what are the indication for single contrast, what are the concentration used. So we'll touch upon that. Then what some specific technique to highlight specific findings. Then this is a problem which is across all cases, proper description of finding and justification for differential diagnosis. This is not unique to barium. This happens in nearly every case, and this is here most of the things go wrong, right? And so you need to be very careful about that. So first to talk about the type of studies. So what we have is a barium swallow. Barium swallow is basically from the cricopharyngeal junction to the J junction. You can see this is the area of cricopharyngeal junction, and from here this is the area of J junction. So this part is called barium swallow, and usually you also have a look at the stomach in the same sitting. Okay, but the main emphasis of the study is on esophagus. Then coming from the from here to barium meal. Barium meal is you do a fluoroscopic study of the esophagus, and you carefully examine the stomach and the duodenum from the G junction to DJ flexure. Okay, so that is the barium meal upper GI. Barium meal follow through is from the DJ flexure to the ileocecal junction. So this would mean evaluation of the jejunum, the ileum, and the ileocecal junction, and also cecum. So they are all part of the barium meal follow through study. And then barium enema, of course, that is for the evaluation from the level of rectum. We inject the contrast in a retrograde manner, examine the entire colon cecum. And if there is reflux of the contrast due to incompetency of the IC valve, we may be able to see the distal ileum also. So just remember that what is the beginning point of an investigation, what is the end point. Means of course we need to see whatever we can see, but we need to see certain areas very nicely as part of the study, so that you need to remember. So these are some of the commercial barium preparation. As you can see, this is micro bar, which is 95 gram and 100 ml. So here comes the concept of weight by weight and weight by volume. So normally we refer to weight by volume when we are asked like what is the strength of barium to be used in this particular investigation. We have to express that in terms of weight by volume. So weight by volume is what I would say, for example, in 95% weight by volume would mean that you take 95 gram of barium and keep on adding water to it till the volume of solution becomes 100 ml. It is not that you take 95 gram and then you add 100 ml. Okay, so just remember that. And weight by weight is same, that you take 95 gram and keep on adding water till the weight becomes 100 gram. But most of the viva would occur in terms of weight by volume. And this microbar HT is used for basically double contrast study of mainly of the upper GI. So let me just tell you about the concentration also. So here, just remember, there is a general rule of thumb that the barium swallow and the barium meal upper GI, we do double contrast in 200 to 250% weight by volume. So remember this figure, 200% weight by volume or 250% weight by volume. And then we divide it by 2. Single contrast, it is 100% weight by volume. Okay, this is for barium swallow and the upper GI. And for small bowel enema, which is the double contrast study of the intestine, you have 100% weight by volume. And for barium meal follow through, which is a single contrast study for the small bowel, it is 50% weight by volume. And similarly for enema, again you reduce everything by half. That is, for double you have 50% weight by volume, for single you have 25% weight by volume. So remember that figure of 200 and then keep on doing 50% of that. 50% for double contrast, for 50% for single contrast, 50% for various segments. And the swallow and the upper GI, they generally for this purpose form one segment. That is, they have similar contrast density for double contrast 200, for single contrast 100. Okay. So this is about the concentration. Now indications and concentration I've talked about. Double contrast is basically the investigation to go to do anything, because in barium what we are seeing is the lumen. Okay, so we need to see the lumen very well, we need to see the mucosa very well. So for that purpose the lumen should be well distended, the mucosa should be well outlined. So we should have a good amount of distension which is achieved by using air, and then we should have a good coating which is achieved by using barium. And single contrast, where it is used, it is actually used where we cannot use double contrast, right? That is one rule of the thumb you need to remember. As far as possible, we need to do double contrast. Where we cannot do double contrast, we do single contrast. What are these situations? Extreme of age, that is in young children or in elderly. If the patient is debilitated, he will not cooperate, because we need a good cooperation for doing a good double contrast study. If he cannot cooperate and we have a specific concept to answer, then we do a single contrast. And when there is a limited objective, like for example in a barium swallow, the physician has done an endoscopy and he finds a tight stricture and he cannot negotiate, endoscope cannot go through this. So they need to know what is the length of stricture. For example, a patient with caustic injury, it may have a long stricture. So if they decide to operate, if surgery needs to be done, so we need to know the length of the stricture, plus we need to know whether there is an additional stricture. So under this situation where this specific question is there, we should be doing a single contrast swallow. Okay, this I have told you, swallow and meal and follow through small bowel enema. Small bowel enema is basically a double contrast study of the small bowel. Here what we do is we have this billboard outer tube that is negotiated through the stomach, through the duodenum, and it is taken beyond the DJ junction into the proximal jejunum, and through that tube then slowly the barium as well as air is introduced, or some other methyl cellulose and all they are introduced. So mostly this investigation is not done these days. This has been replaced by cross-sectional imaging studies like CT enterography or MR enterography and enteroclysis. But this might be asked to you, what is small bowel edema? And so that is what you need to know. All right. So just a brief question, what you can see in this image, what is happening? So quickly type in your chat box, what do you think it is? First, what is this study? And then what do you think is the finding? Quickly. Yes, any response coming, madam?
So one has implied enema, means barium enema, and 4-5 of them are saying barium enema.
Okay.
Then one of have said enteroclysis.
Right. So see, this is the problem: barium enema versus enteroclysis. So enteroclysis is basically small bowel. Small bowel you would be seeing in the center. This is a study which is outlining the peripheral part of the bowel, and you can see this is typical how this colon is placed anatomically. We all know this by anatomy. So definitely this is a barium enema. And if you look carefully, you can see that there are this little small filling defect which are there. So we don't know what is this, whether this is fecal matter or whether this is some mucosa, and because of this single contrast, many of these things they are seen faintly, they are almost obscured, right? So when we do a double contrast study, as you can see in this case where the air has been injected and now we have done a double contrast enema, you can see there are multiple filling defects and the colon is studied with this small nodular filling defect. This was a case of familial polyposis coli with multiple polyps in the large bowel. So I have kept these two images just to show you that how much difference a double contrast study can make to the quality of your examination, to the quality of your reporting. So again, remember, as far as possible, double contrast, do single contrast when you can't do a double contrast. All right. Now, there are certain questions that may be asked to you sometime, normally not asked always, but this is something which can be asked, and then you need to remember this, how to kind of demonstrate a small hiatus hernia. So here the answer is you make the patient left prone oblique. If you the receptor is on the top, if you're doing a fluoroscopy, the tube is generally below the table and the receptor is on the top of the table. So this position is defined in respect to the receptor position of the patient. So the patient is left side up, the back touching the film. Then you put some device like a cushion or some solid thing beneath the upper abdomen, so that to increase the pressure on the stomach. So if there is small hiatus hernia, that would be demonstrated. LPO with some device to increase the intra-abdominal pressure, that would be good enough to demonstrate a small hiatus hernia. But there is a belief that clinically significant hiatus hernia is spontaneously seen on barium study, so this procedure may not be required. Barium study with increased sensitivity of endoscopy, even small hiatus hernia can be diagnosed by endoscopy, and for this indication, barium study may not be required. But in case, if you have an examiner belonging to that era, and if you ask that question, you need to know answer to that. Again, next question, how to kind of show a minimal reflux. So best investigation is of course a nuclear study, but while you are doing a barium, and if you want to demonstrate a reflux, is then you reduce the obliquity of the G junction by putting the patient in the right anterior oblique. That is number one. Then ask the patient to take a dilute barium solution, right? You dilute the barium and give it by means of straw and observe under fluoroscopy. So what happens when the patient is drinking the barium by straw? There is relaxation of the sphincter. Okay. So when this relaxation of sphincter is there, and if there is some reflux, that will be seen very nicely on fluoro. So remember, right anterior oblique, and the patient need to be drinking thin barium from a straw. That is the best bet you can have to demonstrate a gastroesophageal reflux. Now this is an important concept, per oral pneumocolon. So here just remember that the contrast is given per orally. So that means it is a barium will follow through, and then we introduce pneumocolon. So that means air is introduced through rectum. So where this is done under the circumstances when on barium will follow through, the distal ileum doesn't kind of fill up very well, or the proximal cecum doesn't fill up very well. It is then so when the contrast bolus, just imagine I just showed you I'll just go back to this. When the contrast bolus in a barium will follow through has reached mid transverse colon, okay, here, and you don't see the right sided colon very well, and you assume that this may be incompetent IC junction, and you don't see the distal ileum very well. So when the contrast column has reached here, you inject the air per rectum. So what will happen? This air would go and this would distend the right sided colon very well. So at least the cecum would be very well distended. And if there is IC junction incompetence, the air would enter into the distal ileum also, and you would see good distension of the distal ileum also. So this study actually in our time we used to do it very frequently, because ileocecal tuberculosis is a very common condition in India, and we had that barium meal follow through option only, and many times you would see that the cecum is not very well seen, INC junction is not very well seen. So almost like in our time, we used to have 6-7 barium meal follow through study, and we would be doing this procedure at least one patient every day. So you need to remember this. Suspected Hirschsprung disease, yes, there are certain things which you need to remember. So this is an illustration for peroral pneumocolon. As you can see that this is the hepatic flexure, the ascending colon nicely seen. The cecum is not well seen. Okay, so what we see is this area is not well distended. So we don't know whether this is poor distension or some pathology occurring there. And this is of course a barium meal follow through study. You can see the ileum is largely filled up. Okay, so this segment is not well seen. Now after giving the air through the rectum, you can see the transverse colon, the ascending colon is very nicely distended, and this segment which was seen like this, not well distended on this, remains poorly distended. You can see, compare the caliber on both sides, very nicely distended ascending colon, very nicely distended lateral end of the cecum, but the medial part of the cecum is not distended well, and you can see these multiple nodular black kind of filling defect in the contrast column, which is being outlined by the small amount of barium being present here, right? And of course the air has refluxed also into perhaps, no, it is not reflux, this is part of the medial wall of cecum only. So here now you are sure that this is not due to under distension. There is a pathology sitting there, which that pathology also is very nicely visualized. So that is the usefulness of peroral pneumocolon. Now Hirschsprung disease, there are certain things which you need to remember. The patients are sent for Hirschsprung disease for barium anemia. It is a very frequent investigation in children. The idea is to know the length of the affected segment, number one, and number two, to know where is the transition point. Okay, so on plain X-ray you will have a hugely dilated colon. So you need to remember one thing, that in normally barium anemia you would dilate barium with water, but if there is clinical suspicion of Hirschsprung disease, we don't do that. So what would happen if we dilute the barium with water? So once that barium has gone into the transition zone, and this entire solution goes into this hugely distended colon. So if it is water which is hypotonic, it would get absorbed and the patient would land up with water intoxication. So if we are mixing the barium with saline, it is isotonic, it will not be absorbed, and there would not be any risk of any water intoxication. Number two, you need to understand that you have to terminate the study. The idea is to just define this junctional zone and then stop the study. We don't want this barium staying here. This is not a proper study. A lot of barium has gone into proximal colon on the left side. So the ideal investigation would be, as soon as we are able to see this area, a narrow colon, and then this junctional zone, and then this distended colon. So at this point, it should have stopped. Okay. So that is something you need to remember. Another question which is asked, where to put the cannula, how far to put it. So this should be, minimum, to the minimum extent that you are able to do the investigation technically well. So that thing you need to remember. There is no rule that it should be inserted not beyond this, because sometimes there could be just ultra short segment which might be present distally, and in those cases you need to take a special precaution that you need to kind of pinch also the buttocks if needed, pinch also at the level of cannula, because supposing you advance by 1 to 2 centimeter and you directly enter the distended segment, so you know that the junctional zone is lying somewhere more distally, so you have to come back and kind of enter the orifice again, try and pinch that area to outline that ultra short segment, and then kind of delineate that junctional zone. Okay, so just remember that, and then again take a 24-hour film. If the barium remains in the proximal segment even after 24 hours, that is an additional confirmation that this patient is having Hirschsprung disease. Okay, so once again, do it with saline, stop when the junctional zone is demonstrated, and take a film after 24 hours. That thing you need to remember while doing barium anemia for Hirschsprung. Okay, now again, most of the time you would be seeing a stricture or filling defect on barium study. When you see the stricture, the question is whether it is a benign stricture or malignant stricture. There are certain distinctive features which are seen. This is a case where we see a benign stricture. This is a malignant stricture. So what you can see is benign stricture is usually long. So the question is how long is long and how short is short. No clear-cut answer. Perhaps in some book it is written that it may be 5 centimeter, but generally if this question is asked, if you say 5 to 6 centimeter, the examiner would be satisfied. Okay, so remember, short segment up to 5-6 centimeter is short, more than that is long segment. So that is one. Number two is that there will be tapering margin in cases of a benign stricture. You can see this is dilated esophagus, and then there is gradually tapering margin from both sides. Number one. Number two, that the lumen of the stricture would be central. Compare this with this. Okay, this is not gradually tapering. There is sudden cutoff. There is dilated esophagus, and then there is just cutoff. Number one. Number two, it's a short segment stricture. Number three, the lumen is eccentric, because the growth of the these malignant strictures caused by the growth, there is asymmetric growth, uneven growth is there, because of which lumen is not central, lumen is eccentric, and you would see, because there will be tumor on this side and tumor on this side also with an eccentric lumen, so this causes that apple core defect also. Okay, so I hope this is clear. If not clear, I would be willing to repeat this again, because this question would invariably be asked whenever you get this stricture as part of your barium examination. This is going to be asked. Okay. So now we start with actual cases, that is how to determine where is the lesion lying. So first you have to understand the basic concept of what are the various pathologies which can happen in GI tract. GI tract, this is a hollow tube with the lumen. So you have a mucosa. The lesion could be involving only the mucosa. Purely mucosal disease would be there. So these lesions are called epithelial lesions. Then rest of the lesion which extend deeper, or they are only deep, not involving mucosa, they are called subepithelial lesion. Okay, so we have epithelial, subepithelial. Then subepithelial can be intramural, that is they are present in the wall of the GI tract anywhere, be it stomach, intestine or colon. And there could be extramural, that is lying outside, the lesion which are present outside and they just indent the GI tract. All right, and also remember that there might be combination of this. This is not true that the lesion would be either purely epithelial or purely subepithelial, purely intramural or purely extramural. Any lesion can involve all three layers. It can involve wall. It can be an extrinsic lesion which first invades the wall, then it also invades the mucosa. Okay, and this could be a lesion which could be partially in the wall and partially outside. So this could be having both endophytic as well as exophytic component. and there could be a lesion which could be purely exophatic. So all kind of combination do occur. Can we guess on the basis of barium pattern what is involved and what is not involved, right? So this is the first case. What we see here, that you can see there is obvious mucosal fold thickening here. So mucosal folds are thickened, irregular, nodular. You can see this irregular mucosa. Normal mucosa should be very smooth. You can see that mucosa is not smooth, it is nodular, irregular, and there is this big filling defect, and the mucosal thickening is there. And same thing you can appreciate on this also. This is outlined by air here. Okay, so this, what this tells us, that mucosa is definitely involved. Okay, because we are seeing obvious mucosal irregularities. All right, so that much in this only you can deduce that this disease has definitely a mucosal component. Okay, so mucosal irregularity means mucosal thickening, means irregular mucosal thickening means that mucosa is abnormal, right? And that you need to report. So this is a sort of the barium study combined with the CT images. That is how I am going to make you understand. That is, first show you only the barium, then show the barium along with the CT, so that you can correlate the CT image with the barium image, and then remember how to interpret it, taking the thing backward from the CT and then remembering how to interpret a barium study. So what we have here, that see, this is the mucosa. There is this mucosal filling defect here, right, which is also involving the wall. This is the normal wall. This lesion is going beyond the wall. So on barium, what you could tell, that definitely there is mucosal involvement. On CT, you are not able to tell whether the wall is clearly involved or not. But on CT, that decision you can make. Okay. Now, this is another case, patient presenting with bleeding. What you see here is that there is this filling defect. There is this smooth filling defect with a central barium dot. So important point here to note is that there is this mucosal filling defect, but the mucosa itself is very smooth. So this kind of pattern would favor that this lesion is subepithelial. Okay, subepithelial means it is purely subepithelial. Smooth contour means the mucosa is not involved. So you can safely say that this is a subepithelial lesion, and there is this ulcer present within this. A small ulcer is there. So you can see this is outlined by air. Again, you can see very nicely that the outlines are very smooth, and there is this small barium collection which is due to ulceration. Okay, this is, if you can demonstrate it and on very nicely, but even if you see an appearance like this, a wide kind of filling defect with smooth overlying mucosa, that attempt should be made if you have a fluoroscopy to obtain the, this pathology in a tangential view that illustrates the features very well. Okay, but a smooth mucosa generally means the pathology may be subepithelial. So this is the barium along with rest of the investigation. What you see here is, this is an ultrasound where you can see that this lesion is present here beneath the mucosa. Mucosa is highly echogenic, as you can see here. You can see here, and there is ulcer. You can see that there is small depression in the mucosa, and there is this lesion present, which is present in the wall of the stomach. And this is the CT scan, which shows that there is an enhancing lesion which is present mainly in the wall, and the overlying mucosa is mostly normal. You can see a normally enhancing mucosa. So just compare this mucosa with this mucosa. There is a marked difference. Here the mucosa is thickened, irregular. Here the mucosa is very smooth, very nicely seen on CT. And also now if you go back, you can see the same thing on the barium also. So you can say this is a subepithelial lesion, right? So third case. Now what is happening here? So there is this big filling defect. Can you appreciate that this all is filled with barium? This is a single contrast barium. This patient was a little sick. But what you see, that there is this big filling defect which appears irregular. And what you see here is that this is making an angle of 90 degree. So if you have this angle of 90 degree kind of thing, so that tells us that this particular disease definitely has an intramural component. Okay, and then if you see here on this image, that there is an exophatic component also, which is very nicely seen as a soft tissue density. So if you combine this with this, you can make it out that this particular lesion has an endophytic as well as an exophytic component. So that is how you report it. You make a differential diagnosis of intramural as well as combined intramural and extramural disease process. So doing a CT scan, again, what we see that this is the intramural part. You can see the mucosa is normal. Okay, it looks normal. This disease is there in the wall, plus it is also extending beyond the wall. Okay, so combined intramural, extramural kind of process. So combine this appearance with this appearance, exactly similar. So see this image and this image, they exactly look the same. Okay, so you can, when you see a barium like this, then you can make your conclusion, yes, this could be a combined intramural, extramural kind of lesion. Now this is another case. What is happening here? This is stomach. Okay, this is the antropyloric region. What you see here is that there is narrowing of the antropyloric region, and there is thickening of mucosa. So that means there is some involvement of mucosa somewhere. But if you see here, the mucosa is smooth. Okay, so there might be mucosal edema. And then you see there is a huge indentation on the barium column, and this area you don't see any bowel loop. And you see that this particular filling defect kind of thing is having a broad area of contact with the GIT. See, it is extending from here to here, and it is making an obtuse angle. So remember that mediastinal versus parenchymal concept in the chest imaging, chest X-ray. Same thing is applying here. Okay, you have a lesion with broad base towards the lumen, a lesion which is forming obtuse angle. Okay, a lesion which is showing very sharp margin. So these are the features of a lesion which has a good extramural component, or maybe largely extramural, or maybe only extramural. Okay, so just remember that. CT scan of the same patient, you can see here the appearance, the picture getting replicated. There is this huge cystic mass which is indenting the pylorus. You can see mucosal thickening present here. So this was a large pseudocyst which was indenting the gastric antropyloric region, and that you could now, after seeing both barium and CT, just go back to the barium and see how a purely extramural lesion looks like on barium. So you should be able to make that diagnosis. Okay, another case, this is a double contrast upper GI study where you see that there is, this stomach is well distended, mucosa appearing smooth. What you see here, duodenal cap is dilated and the first part of the duodenum is dilated. Now, if you follow the contour, this is the medial wall of the duodenum. If you follow, this is fairly nicely seen. But now if you come to the lateral wall, you can see that there is this small indentation here occurring in the lateral wall. Okay. So normally, if this was normal, it should have gone like this. Just imagine if it was a normal kind of duodenum, the wall should be seen here. It should be joining like this, but it is not happening like that. Okay, there is indentation on the lateral wall, and you can see the mucosa is more or less normal. There is no irregularity, not much of thickening. You would this degree of mucosal thickness is normal in cases of duodenum. So what we deduce here is that there is eccentric impression on the lateral wall of the duodenum. There is no intrinsic disease because the mucosa is normal, and this mucosa is normally placed, and there is medial deviation of the lateral wall. Okay, so most likely this is an extrinsic process. This is classic appearance of annular pancreas. This you can see on CT also. You can see this is the pancreatic tissue on the lateral wall of duodenum, and the duodenum is trapped inside this. Okay, and this is how it is appearing on barium. This can actually come to you as a short case or a spotter also. Now another pattern. This patient presenting with pain abdomen and hematemesis and melena. So what you see here in this initial image, you can see this is barium in the duodenal cap, and there is this contrast going from the first part laterally. So this could be second part, or this could be normal, this could be anything. Now we inject more contrast. What we see, this is the cap being outlined, and then this is the barium from here is going into two places. It is going here, and then it is going here. Can you appreciate that? This is very important to appreciate. Now, if you follow this barium column, this is going down and it is coming down into the D2, D3. You can see the duodenal mucosa very nicely present here, whereas this barium pool doesn't have any mucosa. This is just an kind of irregular kind of barium pool is there, which is not showing any mucosal pattern and which is not conforming to the outlines of the GI tract. This is the GI tract present here. So that means this barium is lying outside the lumen in some cavity. That is the interpretation. Because I can see a normal anatomy here and this is abnormal. So this has to, since it is communicating with lumen, this has to lie outside. Okay, so that thing you need to interpret it that way. All right, this is the CT scan where you can see that this is a case of gallbladder carcinoma. You can see thick walled gallbladder. Here you can see this gallbladder mass that is infiltrated into the lateral wall of duodenum, producing this fistula. The medial wall is perfectly okay. So this particular air was the one that was communication with the lumen of the duodenum, which was giving rise to that collection of barium which was present outside the GI tract. So remember, you first decide, is the normal anatomy seen? Seen, yes. And if this conforming to the normal anatomy, it is not. So either this is something which is leaked outside the wall, or this is some ulcer inside the mass. So these are the two interpretations of this kind of contrast accumulation. Same thing happening here. Okay, almost same picture, duodenum, normal duodenum, and this irregular kind of contrast collection here. This irregular kind of contrast collection. This is the initial image where I could see the contrast only till the D2. This is the late image where you see the cecum has almost begun to opacify. So the entire small bowel has got opacified, the ileum has got opacified. Normally this thing, if it was a normal part of the GIT, the contrast should have left here or would have changed in configuration, but that is not happening. This image, the timestamp is there. There is no timestamp in this. Okay, but this is persistent. Another important thing to note that you don't see any loop here. Normally, you should be seeing some loop present in this area. You should be seeing ileocecal junction. And also you can see some minimal impression maybe, that is doubtful, but this is sure that this contrast is lying outside the lumen, and the fact that you are not seeing any bowel loop present, at least here you should be seeing some bowel loop. So here the interpretation is, again, this is a cavity which is communicating with the lumen and there is some mass effect because there is no bowel present here. So possibility could be that either this is a collection or this is some mass which is got ulcerated and communicating with the duodenal cavity. Okay, so this is the CT scan where you see there is this big huge mass and this positive oral contrast is gone into that, which corresponds to this cavity. This was a case of GIST. Okay, GIST with ulceration which is communicating with the cavity. Okay, next case. So I hope I am not going too fast. Okay, so what we see here is that there is widening of the C loop. So people ask me, what is the criteria for widening of the C loop? Well, there is no definite criteria. It is mainly subjective. As you do more and more cases, see more and more cases, you would know that this is widening. And plus one important indicator is that you would see impression on the inner side, as you see here, right? So that means there is widening of the C loop. And what you see here is that this is the lumen which is normal, and then there is sudden dilatation of lumen. So this is what is known as the aneurysmal dilatation of the bowel. So this particular feature is seen in pathologies which cause destruction of the mesenteric plexus in the wall. So causes are, most common cause is lymphoma. Then any other pathology like adenocarcinoma, it can also cause that. So this is how a pseudoaneurysmal bowel dilatation looks like. So when you see like this, first possibility of lymphoma should be suggested. And this is the CT scan where you can see all the features of lymphoma, that you have this huge mass which is hypodense, minimally enhancing, extending into the mesentery and encasing the vessels in the mesentery. And this is also obstructing the distal CVD and the pancreatic duct. This was a case of lymphoma. with pseudoaneurysmal dilatation of the lumen. So you can see this is the characteristic of lymphoma, that despite such a large size, there is no obstruction. On barium, you see the proximal loop of bowel are absolutely normal. So I have got a few cases where I'm just expecting that these are kind of different cases, but with same principle which we saw till now. So I would request that the people should answer this, and so that we move ahead quickly. So Dr. Mitusha, just let me know. Okay.
Yes.
All right. This is first case. Where is the pathology? Which part is abdominal? You know, this is upper GI. You can see the stomach. You can see the duodenum. This is the D1, D2, D3, and you can see the duodenum. Okay. So where people think that the pathology is there? This is just a little bit zoomed image. Any response coming?
So one is replied D1.
D1. So D1 is dilated. If you look carefully, the problem is here. This is the dilated lumen, and as we come down to D3 and D4, there is narrowing of the lumen. Can you see this? And this is, it is seen a little better here on this image, that this is a short segment kind of dilatation. Okay, short segment stricture is there, and if you see, the lumen is eccentric here. The lumen is coming here, and this is the normal lumen. This is the upper wall, this is the lower wall, and the lumen is present here. So eccentric lesion is there. It's a short segment stricture. Okay, so more likely to be benign or malignant. And you can see some shouldering also.
Malignant.
So, right. So that is the interpretation. So this is more likely a malignant pathology. The fact that this is short segment, it has eccentric lumen, and you can see some mucosal irregularity here in this segment. So this was a case of duodenal adenocarcinoma. As you can see here, mucosal thickening present here. You can see that shouldering effect, small mass, area of marked narrowing, and this is on the CT scan. This is going outside the wall, and also you can see some small lymph node also in the mesentery. Okay, so next case. So this is stomach, this is duodenum. What is the abnormality which is happening? So is the mucosa normal or abnormal?
So they are saying, sir, wide C loop.
Widened C loop, right. So you can see there is some indentation on the C loop. Anything else? You can see there is increased retrogastric distance present here. Normally we take it up to width of one vertebra. That would be a normal retrogastric space in a perfectly lateral view. All right, so widening of C loop is there. Then if you look carefully, you can see this contrast is going out from the duodenum and spilling out for quite some distance. So what does this mean? Widening of C loop means that there is something outside the duodenum. So that is sure there is some extrinsic component. Okay. The fact that the contrast is extravasating, so that means the mucosa has been infiltrated, invaded, and there is this whatever it is, that process which is causing widening of C loop is also connecting with the lumen. Okay. So widened C loop, irregular collection, extravasation, and if you see here, there is some thickening of the mucosa present here. All right, so these are the findings on this barium study, and when we do the CT, what we see here is that there is a large mass involving the body and the tail of pancreas, and you can see that what we saw, that mucosal disruption that can be seen very nicely. There is this large mucosal ulcer. This is a hypoenhancing mass. So this was a case of carcinoma body and tail, which was invading the stomach, right, and also causing widening of the C loop. All right, so again, I think by now you know that there is widening of C loop. Okay, and definitely there is some extrinsic process. It has all the component of an extrinsic lesion. There is broad base, the angle is obtuse. You have seen the normal duodenum. The mucosa, what is the status of mucosa? That is the question I have. Is it normal or abnormal?
Sir, mucosal irregularity, abnormal.
people feel that mucosal irregularity is there, but if you see, we have seen the previous barium, this kind of mucosa is normal in the duodenum, and you can see it is a very smooth kind of impression if you see. And anything else you can see on this, you can see this calcific densities are there. How much time has gone, Dr. Mithusha? I have been given 45 minutes for this.
I think around 20 minutes.
20 minutes are left or gone?
Gone.
Oh, so I can relax. Actually, I thought this would take longer time. So what we see here, definitely there is widening of C loop with a smooth extrinsic impression, suggesting that the mass is extrinsic. The mucosa appear normal, so most likely mucosa is not invaded. What else is seen here? Any response in this
Sir,
area?
they're saying extrinsic impression, calculi, pseudocyst.
So there are some thick calcific densities are present here. So yes, pseudocyst would be a good DD, and it's a child. So yes, pseudocyst would be a very good DD. All right, so this CT was done. What we see on ultrasound, there is this mixed echogenic kind of mass. On CT, what we see that there is fat density and soft tissue density present within this. So this was a case of retroperitoneal teratoma, which was causing that widening C loop kind of picture. Okay. Another question. So what we see here, this is stomach, duodenum, small bowel. Okay, and in this last image, we can also see part of the large bowel. So what is the abnormality? Any response?
Paucity of pelvic loops.
No loop in the pelvis, right? There is no loop in the pelvis, right? What else? Anything else is there?
Aneurysmal dilatation, pelvic lipomatosis.
Aneurysmal dilatation, pelvic lipomatosis. So aneurysmal, if there is pelvic lipomatosis, that is an extrinsic process. Why would that cause aneurysmal dilatation? Right, the bowel would be normal. Only thing that would be there in case of pelvic lipomatosis, that the bowel would be maybe kind of clumped in the center, but you would be seeing a normal mucosa. All right, that kind of thing is not there. You don't see any mucosa present here, and you would actually see a very smooth kind of indentation of the bowel on both sides. Instead, if you look carefully, this thing has come. This timestamp is not clearly visible, but there was a gap of nearly 1 hour between this image and this image. Okay, because you can see the colon is also very nicely seen here, whereas it is not seen here. So again, and what about this barium collection? If it is bowel, has it got the shape of bowel? Is it the normal bowel? The normal bowel is seen here. This is all bizarre shape kind of collection. And there is no pelvic loop present here. There is no mucosa present here. So most likely explanation again is that there is this, either barium present in a cavity, and since the mass effect is there, so most likely explanation is that there is this big mass present here in the pelvis, which might have got ulcerated. Okay. So this is the CT scan where we see that there is this mass lesion which is showing an endophytic component, which is also showing a large exophytic component. You can see the normal wall of the GIT being present here. All right. So, and you can see this is the lumen, and this is where this ulcer in the mass is connecting with the lumen. And you can see the enhancement pattern. So you know from your CT what is this most likely to be. Answer? Any answer coming? So this is
lymphoma.
This is GIST. See, lymphoma, there will be circumferential thickening. Here, there is no circumferential thickening. This wall is normal, and this wall is showing endophytic as well as exophytic component. So this is a case of GIST. And lymphoma won't have these kind of vessels supplying the mass. This is a kind of heterogeneous, predominantly enhancing kind of there. You can see too many vessels present here. So this is an example of GIST on cross-sectional imaging. All right. So next case. Where is the problem?
Central paucity of loops.
Central paucity of loops, right? So there is central paucity of loop. Not only that is there, if there is anything else also along with paucity, you can see there is indentation on this loop of bowel. Okay, on the mesenteric side. This is the mesenteric side, and there might be some minimal thickenings in some of the mucosal fold, like this one may be thickened. Some mucosal thickening is there. So there is this paucity of bowel loop, and this particular area is surrounded by bowel loop on all sides. So that is an important finding. This kind of picture is seen in a mesenteric lesion. So mesentery, if some mass lesion is there, that would displace the bowel around it, all around it, and you would be seeing bowel all around it. So this kind of picture is suggestive of a mesenteric mass. Just remember that. So even in this image also, there are small bowel loops all around this. In the later section, again, this area is not filling, but it is surrounded by small bowel loops all around. So this is a feature of mesenteric mass, and you can diagnose a mesenteric mass with great confidence. So what we see on CT here is that there is this necrotic conglomerate lymphadenopathy of tuberculosis. You can see that. So tubercular mesenteric lymphadenopathy, which is causing splaying of the small bowel loop around it. So that is how it looks on barium. Just have a look again. This is how a mesenteric mass would look like. All right, what is this investigation? That is my question.
Barium meal, they are saying, sir.
Barium?
Meal.
Okay, barium meal. What all parts we are seeing? What all parts of GIT we are seeing here? Okay, let me be more specific. What is this? This is the dome of diaphragm. So which organ is this most likely to be?
So they are saying stomach.
Stomach. And what about this? This particular structure?
Colon, transverse colon.
Right. So in the same image, what you are seeing that the stomach and colon are getting filled up. Okay. So what is that condition known as? So what is happening? So they are communicating, the lumen are communicating, and there is a gastrocolic fistula. You can see this is stomach, this is the pyloric end, and here there is communication, and you can see the colon also communicating with the stomach. Now the question is whether this is filling, whether this is barium meal upper GI and from there the colon is filling, or is it a barium enema study from where this stomach is filling? Any response on that? I think most of the people, they said it is an upper GI study. So in upper
they're
GI,
saying enema.
they are saying enema. So that is a very important point to remember. If there is a gastrocolic fistula, it is more likely to be demonstrated in the barium meal enema study. Unless it's a huge fistula, it will not be demonstrated in an upper GI study. So if the question is put to you, which study you need to do for a demonstration of a gastrocolic fistula, the answer is barium enema. The reason is that the colon is a high pressure zone. So if there is a fistula, the barium would definitely go from a high pressure zone to a low pressure zone. So if you do an enema, the barium would go. If you do an upper GI, since stomach is a low pressure zone, it is unlikely, unless it's a very big gap, you would see the barium going from stomach to the colon. That possibility is highly unlikely. Okay. So for demonstration of gastrocolic fistula, the barium enema is the investigation of choice. You can see the barium in the transverse colon. You can see this is the mass. You can see this large irregular mucosal filling defect in the transverse colon on the upper side, and this filling defect is extending into the pyloric cavity also. And had this been upper GI study, you before you see the colon, you would definitely see small bowel. You don't see any small bowel at all. You just see the colon and then you see the stomach. So this clearly means that the contrast is going from colon into the stomach. Okay. So this is also colon. This is the ascending colon. Okay. So this is a barium meal upper GI. So where is this lesion located? Whether this is purely mucosal or whether it is in the wall or whether it is going outside also. That is the question. So how do you decide that? You look at the contour. Is the contour smooth or irregular? If the contour here is smooth, so most likely the overlying mucosa is normal, and the angle is nearly 90 degree. If you see on this wall, the angle is nearly 90 degrees. So most likely it is an intramural process, even though it has a wide base, but because the angle is not markedly obtuse, so this is more likely to be an intramural process. This was basically this is the barium study where this was a case of intramural lipoma. This is the ecogenic ecogenicity which you see in case of a lipoma. All right, again to highlight the features of a mass which would be predominantly intramural or exclusively intramural. Okay, now I think I have only bariums and I'll be concluding the talk very soon. So what is happening here? What is this study?
So they're saying barium enema.
Barium enema, right? Because you can see the mostly what we see here is the colon, and this small amount of small bowel is seen, which could be due to maybe the ileocecal junction is refluxing. It is not competent. Okay. So what is the abnormality? Where is the abnormality? Yes, any answer on that?
So they're saying, sir, ileocecal junction is patulous, cecum and ascending colon.
So if you see the ileocecal junction, the ileocecal angle is normal. Yes, it is patulous because contrast is going into terminal ileum. So definitely it is patulous, but the ileocecal angle as such is normal. It is not obtuse. Instead, what you are seeing are these multiple irregular filling defect. Can you see this? There are multiple irregular filling defect, and in this double contrast study, you can see multiple areas of mucosal thickening, and you can also see a polypoidal filling defect. But the disease is predominantly a mucosal disease because the mucosa here is abnormal. Okay, this is thickened, abnormal, polypoid filling defects are there. So this was a case of carcinoma cecum. This cannot be labeled as tuberculosis because cecum otherwise shows normal distension. It is showing multiple filling defect. It is not a thickened contracted cecum, and the ileocecal angle is absolutely normal. Okay, so this is the reason that this is predominantly a cecal mass. This was a case of cecal adenocarcinoma producing these multiple nodular filling defect kind of thing. All right. Again, let me just tell you that this is a barium enema, but where is the problem? What is the most likely diagnosis in this? Which segment of colon is abnormal?
So they are saying the lead pipe appearance ulcerative colitis.
Lead pipe appearance ulcerative colitis. I think that is what I expected also. So if it is ulcerative colitis, we know that if it is lead pipe colon ulcerative colitis begins from the rectum, and what is happening to the rectum here? Is the rectum normal? Are these hostile folds normal, or are these abnormal? These are involved. So as you can see here, the colon has a normal kind of morphology. It is this segment which is showing mucosal abnormality, and it is showing a stricture present here. Again, mucosal abnormality here and a stricture present here. Okay, in case of ulcerative colitis, lead pipe colon, this segment has to be necessarily abnormal. So as you can see here in this stricture, although they are short segment stricture, but you can see that there is gradually tapering margin and the lumen is central. So these are essentially benign strictures. They are multiple. So differential diagnosis, and they are circumferential. You can see the entire wall is narrowed. There are no skip area in the wall, although the different level of bowel are involved. So first possibility here would go in favor of an infective disorder like tuberculosis or some other infection. And Crohn's colitis would also remain as a differential diagnosis, but because this segment of colon is normal, ulcerative colitis is not a possibility. All right. So what is happening here? So what we see here, that there is an abnormal fluid level present on the right side. Normally we don't see the duodenal fluid level would be somewhere here. It won't be so high, but there is an abnormal fluid level. This could be in the liver, this could be in the duodenum. This patient came to us with persistent vomiting, right, and showed this kind of fluid level. So we would assume, if we have this kind of history, that this fluid level is in the duodenum, but it is definitely on a higher side. So the understanding is that maybe the duodenum is dilated. Okay, and this was the barium. This barium has a characteristic appearance. What is this diagnosis?
So they are
So
saying malrotation.
yes, so as you can see that the duodenum is, this is the second part, this is the third part. The duodenum is not crossing the midline, it is turning towards the right side, and then it is kind of going into this corkscrew pattern kind of appearance. So not only there is malrotation, because this is not crossing to the other side, there is twisting of the loop also. So this is malrotation with midgut volvulus. This characteristic appearance is known as the corkscrew duodenum or the corkscrew configuration of duodenum, which is diagnostic of a midgut volvulus. All right, same pathology, two different patients. So here what you see, is there some diagnosis?
So the TB and string sign, narrow terminal ileum.
Right, so here what we see, that the cecum is grossly contracted. Okay, so this particular end, it is pulled up. You can see that this is just ascending colon short segment, and then we see the beginning of the this hepatic flexure. So this is classic ileocecal tuberculosis, and here uh, well, the terminal ileum is involved, the cecum is also abnormal. So a clear differential diagnosis between the tuberculosis and Crohn's disease may not be possible, and then we may have to resort to cross-sectional imaging to make that differential diagnosis. That may offer us more insight and enable us to make a clearer diagnosis. So what is this study? That is first question. Complete description of the study.
A double contrast enema and interception.
So in double contrast enema, you would be seeing only the colon, but what you see here is part of the stomach, part of the duodenum, and mostly you see the large bowel. So this is definitely barium meal follow through, and in the follow-up images, what you are seeing, that there is this air present in the colon. So this is again, because at some point the terminal ileum or the cecum area was not well seen, so a peroral pneumocolon was done. So this is a barium meal follow through followed by peroral pneumocolon. So that is about the study, and what is the abnormality present here? So although there is just one image, what you can see that this is the area of terminal ileum or the cecum, and here there is this collection of barium, which is could either be due to dilated lumen, or that which could be due to barium lying outside into a mass lesion with cavity, and you don't see any loop present here. So these are the two possibilities, that this could be an erythemal dilatation of a lymphoma, or this could also be a gist with ulceration. So this was actually on cross-sectional imaging. I don't have the cross-sectional imaging, but this was a case of lymphoma. On cross-sectional imaging, it showed gross thickening of the wall of the terminal ileum as well as the cecum, and this was the pseudoerythmal dilatation of the bowel lumen. So I think, let me see, I think this is the last case. No, there is one more. Okay, good. So this is obviously barium enema. It is written here, and plus you can see that you can see there is left-sided colon, the splenic fascia, the transverse colon, and the ascending colon is well seen. Where is the problem? That is what I want to ask.
So they are saying ulcerative colitis, cecum.
Ulcerative colitis. So here, this is normal. You can see the hostrations present here. Okay. And transverse colon is also normal. And in sigmoid colon, you may not see hostra all the time. So let me just give you that this particular thing is normal. Focus in this area. I know it is difficult. You don't do much of the barium. So it's a difficult proposition. Okay, just let me make the search more narrow. Just focus on this cecum and the terminal ileal segment. Any response is there? Okay, so what we see here, the contrast is refluxing from the cecum into the terminal ileum, and you can see this ileocecal angle is absolutely normal. But what we see below that, there is this very well-defined filling defect, which is having broad base and showing normal overlying mucosa and projecting into the medial wall of the cecum. Now, this particular appearance suggests that this is an appendicular pathology, either an appendicular pathology which is projecting into the lumen of the cecum, or some appendicular abscess, inflammatory collection, which is indenting the medial cecum. So this is how the appendicular pathology present themselves on barium enema. You would see an indentation on the medial wall of cecum, which lies below the ileocecal junction. Okay, this particular case was a case of basically appendicular mucocele, which was projecting into the medial wall of cecum. So this is how it looks on the barium study. So with this, I hope I have been able to cover this difficult topic to your satisfaction. The main thing is to understand what are the features of mucosal disease when we say that when the wall is involved, and when we say that the lesion is also going upside. So I know it is a difficult one and the time is very small. We need more time to discuss and interact. Only then you would be able to understand properly. But still, so if there are any question, I'll be happy to answer.
Thank you, sir, for taking this complicated topic and elaborating almost all the important aspects. There are questions. One is like, how commonly is IC junction reflux seen in barium enema study? Is it a normal finding?
Yeah, if the reflux is seen, that just tells you that ileocecal junction is incompetent. It doesn't tell you whether the terminal ileum is diseased or not. You have to look at the morphology of that segment of bowel to decide that.
Okay, sir.
Ileocecal normal 90 degree. If you see an obtuse angle, that is abnormal. So how you identify ileocecal junction is you follow the terminal ileum. Terminal ileum goes up, right? It joins the cecum at an angle of 90 degree, and cecum below this ileocecal junction. Let me just share my screen again. See, so this is the terminal ileum joining the cecum, ileocecal angle 90 degree, and this segment of the bowel which is present below the level of ileocecal wall, that is what is the cecum. That question may also be asked to you. Okay. Yes, ma'am.
And sir, just they want you to repeat the concentration of barium.
Okay. So remember 200, double 200. So that is the first thing you need to remember. start from the upper part of the GI tract. Esophagus, upper GI, 200, double contrast. So after that, for double contrast, keep doing half. 200 ka aadha, 100 for small bowel, half of that, 50 for large bowel. This is about double contrast. Then for single contrast, half of 200 is 100. So single contrast upper GI would be 100. Single contrast follow through 50, and then barium enema 25. This is just an approximation which would satisfy the examiner. So I hope this is clearly understood.
Yes, sir. I think most of the questions also we have addressed.
Okay.
And I think the important cases also you have explained quite elaborately. Sir, are there any spotters also beside these?
Yes, I have spotters, conventional spotters. So what we are going to do is that I will project the spotter and wait for maybe about 20 seconds for the responses, and would request you to read out those responses so that I can correct if any wrong responses are there and tell them why it is wrong. Okay.
Okay.
So let me just share the spotter. All right, so I have kept about 40 spots. So we need to finish them as quickly as possible. They are all exam spots, simple. But since you don't do so much of conventional radiology these days, so might take a little more time. So let's see. So kindly type in your responses. Okay, this is moving on my own. So I've just seen two responses, pulmonary edema and left mastectomy. So what you see here is that this left lung field is appearing unusually lucent, and if you look carefully, if you see like this in a spotter session, always see the other side. Okay, so first rule out mastectomy. So most of the time, if this is coming to you as a spotter in a child, that would be most likely a foreign body or a CLE. In an adult, this would be mastectomy. So first look for mastectomy. So breast shadow is present here. You don't see any breast shadow here. So this was mastectomy. All right. Right, I think most of you have answered. Ecclesia is not the answer. So let's go to the next one. So what you are seeing here is that there is this big density which is projecting on the right side of the spine. It is coming from the level of thoracic inlet going right down till the mediastinum. This is predominantly soft tissue in the lower part, a mixture of air and soft tissue in the middle part, and the same those air lucency are present in the upper part also. So classic appearance of ecclesia cardia. Right-sided density from the thorax to abdomen. If there is history of surgery, if you see some sternal sutures, then this can be also be seen in cases of colonic transposition. But in that case, usually if that is coming to you as a spotter, you will get a history of surgery as part of the spot. Okay, but if you get it like this is ecclesia cardia. So this is very simple. I think we don't need to discuss. Miliary tuberculosis will have soft tissue density. Is this density soft tissue? You see here on the topo, here you can hardly see any lung. The entire lung is obscured. You can see some lung in this CT, this thing, scanographic image. So this is alveolar microlathesis. Definitely there is miliary shadowing, but this is a high density kind of shadowing, and the entire lung field is obscured. So alveolar microlathesis, that is the most likely diagnosis. alveolar hemorrhages won't be so, that won't be giving you this miliary kind of pattern, and they won't be such hyperdense shadow, or these are nearly calcific densities. Okay, so diagnosis here is microlithiasis. Calcified mets won't be so numerous. If you see an appearance like this, microlithiasis is a more likely possibility than metastasis. Although miliary metastasis can occur, so there are very few metastases which calcify and would be producing a miliary kind of pattern. So alveolar microlithiasis is the safest bet. CPAM1, hydrated, CLE, eventration, CCAM, CPAM. So what we are seeing here, definitely that there is a problem is here. There is this abnormality which is showing here in the upper part, and if you look at the lower part carefully, it is very important to see. See, this is not a clear-cut straight meniscus. This is a kind of wavy kind of pattern. If you see, there is this soft tissue density which is wavy, and you can see there is this slightly radio opaque line here. This is also giving that kind of wavy kind of density. So this kind of picture is suggestive of a ruptured hydatid. Diaphragmatic rupture. So diaphragmatic rupture on right side, if it is there, the liver would go up. This is air. So if it is diaphragmatic rupture, I assume that it is bowel. Okay, so bowel will not have such big. You would see multiple kind of bowel, and you won't see such big single loop of bowel present unless it is obstructed. And this kind of picture, that is pretty typical of a hydatid disease. So diagnosis here is hydatid disease for the same reason, because I am able to see this wavy kind of pattern in the interface between the air and the soft tissue. I would put ruptured hydatid as a first possibility. Yes, effusion. Yes, anything more than effusion. Effusion is definitely there. And the patient came to X-ray for effusion only. But can you see something more? Right. So now people are beginning to see. Okay. So what you see, in addition the pleural effusion, which is extending into fissure, you see these rice-like calcific density which are overlying the chest wall, and you can see a small density present here in the soft tissue in this region above the clavicle. Okay, so this is a myocysticercosis, and this is the clincher. Here, this could be in the lung, but the shape is also typical of a calcified cysticercus, and here it is clearly present in the soft tissue. So that gives you the clue that this is most likely myocysticercosis, definitely associated with effusion. Correct. Classic spotter. I think this everyone should get right. So what we have is a massive cardiomegaly with no specific chamber pattern. Okay, so and very nicely defined cardiac border. So this particular thing, if you see, this is that money bag kind of appearance. Okay, so diagnosis here would be a pulmonary pericardial effusion. History, important. Post mitral valve replacement. You can see there is this prosthetic mitral valve present in the center of the image. Right. So you can see this air collection is there, which is stopping at the root of aorta. All right. And it's most likely a pneumopericardium. Had it been pneumomediastinum, it would have gone up. It could be in form of irregular streak. So how you can differentiate? You can change the posture. You can change the position of the patient. This air position will change, but it will remain within the confine of pericardium. Whereas if it is mediastinum, you would be seeing in the entire mediastinum, maybe extension into the soft tissue, and the position would not change with the change in the position of the patient. So this is pneumopericardium. All right, so I think most of you, all of you have got this all right, but just important one thing I want to say, that there is definite pericardial calcification. You can see it in the anterior pericardium, you can see it in the inferior pericardium. So this pericardial calcification is there. When to call it constrictive pericarditis? When in that case, you should see some features of heart failure. As you can see here, there is bilateral pleural effusion, which is extending into the fissure. So bilateral effusion is there. So definitely the heart is getting constricted. So in that case only, you should say constrictive pericarditis. Although with calcification and pericardial thickening, if you write constrictive pericarditis, that would be accepted. But it is true only when you see the features of heart failure also. But to remain safe, if you see an appearance like this, do write constrictive pericarditis. Okay. So what we see here is that the aorta is normal. There is this abnormal contour to the cardiac border. You can see this inferior contour is projecting little laterally, and it is, this is not a single kind of contour. Supposing this was just plain simple left ventricular enlargement, this border should have come like this. Okay, this border should have come like this. Definitely there is displacement of the apex laterally and inferiorly, so you might get confused with the um, mm, this being left ventricular enlargement. But if you see now, if you were to just follow this contour, supposing this was normal thing, if you had followed, the border should have come like this. Okay, and you would have seen the apex somewhere here, but you are seeing that there is a focal protrusion coming from the apex. So this is a left ventricular aneurysm or pseudoaneurysm. There is focal protrusion. It is not a global enlargement of the left ventricle. Okay. So that is how you differentiate. You follow the contour. If it is following the contour, then it is just cardiomegaly. If it is not following contour and looks like a focal protrusion out of the contour, then it is a left ventricular aneurysm. Correct. Why is trachea shifted? There is rotation. There is rotation. You can see that this is the midline of the spine, and there is gross shifting of this. Because of this, trachea is also shifted. So I'm waiting. Breast implant won't have a shadow like this. There is increased density present here, definitely, but the reason is different. Look more closely. If you see, there is the soft tissue density present here, and if you look carefully, you are not able to see all the border of this abnormality. So that means this is what is known as the incomplete border sign. You can see this border very well. If you look on this image, which is kind of zoomed here, you can see the medial border is very nicely seen, but the lateral border is not very well delineated. And in addition, there is this erosion of the inferior border of this rib. So that means this opacity is related to inferior border of rib, which is causing erosion. It's a smooth kind of erosion. So it has to be, something related to the inferior border, and the vessels are there, a neurogenic tumor are there. So most likely diagnosis, if you see neurogenic tumor, would be more common rather than an intercostal artery aneurysm. So a neurogenic tumor of the intercostal nerve, that is the most likely possibility. Okay. Yes, spotter 11. So Dr. Stuti, tracheoesophageal fistula, anything else? When you say only tracheoesophageal fistula, I assume you are talking of an isolated tracheoesophageal fistula. Yes, there is definitely dextrocardia, that is there, but is there anything else? If you see carefully in this image, this is a tube which is getting curled up in the distal esophagus. The Ryle's tube or this catheter is not passing down. It is getting curled up here. So definitely there is an element of esophageal atresia. And because despite esophageal atresia, you can see the air in the bowel. So that means there is some fistula with the airway. So there is distal fistula, right? So esophageal atresia with tracheoesophageal fistula, that is the correct answer. And of course, there is this dextrocardia is also there. Okay. Classic. Right. I think everybody would get this. Double bubble appearance. No air in the distal bowel. Only diagnosis duodenal atresia. So duodenal obstruction would not be a correct answer here. This will not give you full marks. So duodenal obstruction can be complete, it can be partial, but we don't see any air in the distal air bowel. So there is complete obstruction and it's a child. So you have to write duodenal atresia to get full marks. Duodenal obstruction will just fetch you half of the mark. So is that clear? I think iPad has written this. So that student should know this difference that you call out correctly, and if you call out partially correct, you will get partial marks. Petoblastoma, teratoma, meningomyelocele. Okay, so all of you would agree that there is this soft tissue density present here. See the abdominal wall, this side the wall is bulging, and you can see if you look carefully, especially on this image, there is this bone-like element present this within this opacity. Okay, and I don't know whether it is projecting well. You can see more bones and well, spine you cannot see, but that bony element is there. Okay, so diagnosis here, teratoma I would accept, and fetus in fetu also I would accept. So what is the essential difference between a teratoma and fetus in fetu? Lithopedion, correct. What is the difference? Yes, spinal element. So you have to demonstrate spinal element either on imaging or on histology, especially the notochordal element. Then you call it fetus in fetu, otherwise teratoma is also okay. Acha, in this, I think somebody wrote meningomyelocele. Just would clarify to that person that meningomyelocele would be a central lesion. So it would be projecting mainly in the center and it would be seen on both sides. But if you see this is projecting mainly to the right side and just coming towards the midline. That is number one. Number two, you would be seeing some spinal defect which is not seen. Okay. So that is so this is not a meningomyelocele. That answer should not come with this kind of opacity. Yes, there is pneumothorax. You can see that air is there and you can see the margin of the lung. In addition to that, you can see this air containing cavity is there. So this patient had history of infection about 4 weeks back. So this would go with this kind of history. This would go with the diagnosis of pneumatocyte, and of course, this pneumothorax is there. Emphysematous what? I'm not clear about what do you mean when you say, do you mean empyema or something? Okay, so this is not empyema. Empyema would be showing a fluid collection, not in air. And if it was containing air, you would see a horizontal air fluid level. All right, let's see how many of you are able to pick this. This is a subtle finding. COPD, only one response coming. Fracture clavicle, okay. Loser zone, very good, Sakshi. Where is the loser zone? Scapula. So one, I just keep on emphasizing again and again in my talks that you look at the chest X-ray, the chest looks normal, heart look normal. Immediately go to the bones. Immediately go to the bones. Abnormalities most likely would be there in the bone. Okay, you look at the rib, you look at the scapula, and you look at the humerus. Either you will be seeing rickets here, you would be seeing some osteochondroma present here in the scapula or in the rib, some fibrous dysplasia, that kind of thing would be there. Okay, so here what you see that this lucent kind of linear density is there. There is slight, if you see coarsening of the bone pattern, it appears slightly increased bone density. So that would go with osteomalacia and with the loser zone present in the lateral border of the scapula. Good pickup. Neurofibroma. So this is an obvious diagnosis, right? You can see these multiple nodules which are projecting outside the skin also, right? So diagnosis is not a problem here at all. These are all multiple neurofibromas. Yes, waiting. One response till now, right? So what we see that there is this stent present here. This is obviously a biliary stent. This is along the course of the CBD. So once you have this intervention, you would expect pneumobilia, and you can see this air is present in the left-sided intrahepatic biliary radicals, also on the right side, and you see this air present mainly in the central part of the liver, which is characteristic of pneumobilia. So the answer here is pneumobilia, no other diagnosis, especially with this stent in placement. You don't think of any other thing, and plus this distribution of air is pretty characteristic. Yes, there is biliary drainage, Dr. Bhageshwari, that is also correct. Yes, I am waiting for a few more. Gastric volvulus, if you see on plain X-ray, you would see some elevation of dome and you would see two air fluid level. That is the most likely appearance of a gastric this thing volvulus. Instead, if you see carefully, there is this air density which is branching and which is going till the periphery. Okay, so this is air in the portal vein. You can see this air present here, and you can see air going right till the periphery, especially in this part. You can see very nicely. Okay, most likely cause in children, this is a child, it is necrotizing enterocolitis, although we are not able to see the air in the bowel wall very clearly. But if you write NEC, even that is okay, since the pneumoportalis is there, and NEC is the commonest cause, one of the common causes. So I'll give you full marks, right? Okay, I think most of you saying that it is pneumoretroperitoneum, some saying that this is emphysematous pyelonephritis. So what we see here is that the air is present in the retroperitoneum. Very nicely you can see this is the air and this is the renal parenchyma, and you can see air present in this region also. Okay, but normally if the air is present in the renal parenchyma, what you would see is a streaky opacity which are present in the renal parenchyma. Now this air could also be in the bowel wall. This air could also be in the retroperitoneum, or this could also be in the renal pelvic collection system, but majority of the air is present in the retroperitoneum. So if I were to decide if you are writing this as an emphysematous pyelonephritis, yes, this air is overlying kidney. I would not say that you are absolutely incorrect, but a pneumoretroperitoneum, because majority of the air is present outside kidney, that would be a better diagnosis. So this was a case of basically biliary obstruction where ERCP was done, the duodenum got perforated, and there was leak of air into the retroperitoneum. Right. So this is how the emphysematous pyelonephritis looks like classically. Just go back to this again. Look at this, where you can see most of the renal outline very clearly. And look at this. The entire renal area is kind of filled with air. You can see this streaky opacity, which are due to presence of air inside the parenchyma, and this air is taking the shape of kidney. So this is more representative of an emphysematous pyelonephritis. But as I said, if you write emphysematous pyelonephritis in that case also, I would give it to you. But this is how the classical EPN looks like, just to show that. Scleroderma, corrosive ingestion, corrosive stricture, volvulus. Corrosive stricture is the consensus. All right. So definitely there is this long segment stricture, okay, starting from thoracic inlet going right down till the G junction, and it has a central kind of lumen. All right. So this is a benign stricture, long segment. And why do you call it corrosive? This could be any other infection also. What is the reason for calling it corrosive? So long segment benign stricture can be produced by other infective pathologies also, although you would put caustic. But there is one more reason where you can put the foot down that this is a corrosive stricture. If you see carefully, there is a stricture present here also, right? The antropyloric region is narrowed. So that is another site for a corrosive stricture. So you have two stricture, one in esophagus, one in the region of antropylorus. It is persistent. You can see it is seen in this image also. It is seen in this image also. It is seen in this image also. Okay. So because there are two strictures, more likely to be caustic strictures. Some of the acid is escaped this, and then it has caused narrowing here. So that is the reason. Yes. Gastric volvulus. So just have a good look. What you can see here, this is the esophagus. As you trace it down, this is going down, and the esophagus junction is here, and a part of the esophagus is coming out through the esophageal hiatus into the posterior mediastinum. So G junction is in the abdomen, and part of the stomach, the fundus, is come into the chest. So this is definitely a hiatus hernia, but it is a rolling kind of hiatus hernia, which is more dangerous, in which the G junction remains inside and the stomach comes up besides the G junction. So that is why you are seeing this indentation on the esophagus also. Okay, so correct answer would be a rolling hiatus hernia. But even if you write hiatus hernia, it is okay. I'll give you. You don't see much of barium these days. Well, this particular thing is not getting replicated in this image, so I'll be little skeptical about calling on the basis of just one image ulcer, unless this is more or less the same area, but I don't see it very clearly. But here there is a finding which is more distinctive. What you see is there is barium in the stomach and big filling defect is present here, and within this filling defect the barium has gone inside the filling defect, and you can see these multiple air-like lucencies. So this is a typical appearance of a gastric bezoar. Okay, so you see a filling defect which is outlined by barium. You can see barium present on this side also, barium present on the lateral side also, right? And barium present inside the mass also. And you can see this going into the duodenum also, in the first part of duodenum. So this is a bezoar. Well, to write trichobezoar, it is okay, but you have to know that history of hair should be there. So it is always safe to write bezoar. That is a better thing, covers everything. Okay, whether it is tricho, phyto, or any other bezoar. Bezoar, unless there is a specific history, don't commit yourself. Although nobody is going to detect your mark even if you write trichobezoar, but the correct term would be just bezoar. Right, so multiple perianal fistula is there. You can see this is a barium anema study, and there is this extravasation of contrast at multiple places, all right, resembling the water coming out of a watering can. So this particular appearance is called watering can perineum, and this you can see in tuberculosis and Crohn's disease. All right. If you write fistula in NO, write multiple fistula, and that is a better term, writing a watering can perineum or multiple fistula. Okay. If you just write fistula in NO, because this is a distinctive entity and has a very narrow differential diagnosis, it has a pathology mainly etiology mainly Crohn's disease or tuberculosis. Fistula in NO can be due to localized infection also. Okay. So if you write fistula in NO, maybe I'll give you just half mark. But if you write watering can perineum, that gives you, or multiple fistulas, that gives you full marks. I think this is the diagnosis was made repeatedly in my previous session, right? So classic ulcerative colitis, chronic ulcerative colitis. Here you can see that the colon is abnormal. The entire descending colon has lost rostre and it is featureless. Also involving the transverse and the ascending colon, and there is small stricture present in the region of hepatic flexure. Okay, so diagnosis would be chronic ulcerative colitis with stricture in the splenic flexure. But if you write ulcerative colitis, I would just advise that you write chronic ulcerative colitis or long-standing ulcerative colitis. Lead pipe colon, okay. I'll give you that answer. That answer you will get full mark. So this you've just seen in my lecture. This is harsh tongue, so I'll skip that. History is there. Right, so we have this rectum and there is a fistula between the stump and the rectum. So rectouterine fistula. Okay, it is not vesico, there is no vesical element here. Okay, this is in the vagina. Okay, this is coming from that stump part. Classic dermoid, right? So no scope for discussion. You see this lucent mass with teeth-like structure inside. Okay, teratoma, dermoid, everything is okay. What is this urinar? Shraddha, what did you want to say? Okay, we move to next. Dermoid only, right? Yes, this is copper T calculus. So this patient copper T inserted, got displaced, perforated urinary bladder, came to the urinary bladder, acted as a nidus of infection, and like every infective focus would form a calculus around it. So a calculus formed around copper T. So this is basically a copper T calculus. And you can see that the bladder outline is also nicely seen, the soft tissue density. So this is a present inside the urinary bladder. Okay. All right. So what we see here, if you just mark out the renal outline, it is extending from here to here. This is the upper pole, this is the lower pole. And the normal kidney would measure 3 vertebra plus their disc spaces. But if you count, this is 1, 2, 3, 4 going on to 5 with the disc space. All right, so at least 4 vertebra. In addition, if you see, there are multiple impressions in the pelvic ileal system. At least on this side, you can see them very well. You can see the impressions present on this side. Here also the kidneys enlarged. So this is classic IBU picture of ADPKD. Renal tuberculosis would have normal renal size or a small renal size with fuzzy renal outline or some hydronephrosis. All right, so this cannot be, because this is bilateral and there is enlargement of size with indentation. So ADPKD is the right diagnosis. Right. So I think all of you have got this right in one way or other. This is not a duplex kidney. See, duplex kidney, you would see the normal kidney on the other side also. You are not seeing a normal kidney, and here both these kidney are having complete pelvic ileal system and separate ureters. Right. So this is the right kidney, and towards the lower pole of right kidney, you are seeing the left kidney. You can see this right ureter going down and inserting on the right side, left ureter crossing the midline and coming to the left side. So this is crossed fuse ectopia. Okay, some variation of that. Pancake kidney would have definitely a vertically aligned kidney, but you would be seeing two pelvic ileal system fuse in the midline. Okay, and you would be seeing a single mass. What you see, and you would be seeing two ureter. What you see here is basically one pelvic ileal system. So this is one pelvis, one-sided calyx, this ureter crossing across, and the position of the kidney is on the other side. Kidney is present on the right side, ureter is crossing and coming onto the left side. So this is solitary crossed ectopia. Pancake kidney would be a little different. You would be seeing this more to be in center and with two collecting systems, right? This is not ectopic pelvic kidney, Dr. Kaladevi. In ectopic pelvic kidney, the ureter would be going to the same side. It is crossing. So it is definitely ectopic, but there is crossing also. So you have to write crossed ectopia, solitary. right? So vertically oriented kidneys, the inferior calyx pointing medially, okay, that flower vase kind of shape, classic horseshoe kidney, right? No other diagnosis is possible here, and I think all of you have got it right. What is lipo? Yeah, asking from Dr. AP. What do you mean when you say lipo? Lipomatosis. Okay. So lipomatosis, you won't be seeing such kind of configuration of bladder. You would be seeing a lucent area in the pelvis on both sides, and then you would be seeing bladder assuming a different kind of configuration, a more vertical kind of configuration. But if you look carefully in this area in the bladder, there is this contrast collection with lucency around it, which is horizontally oriented. This is a classic appearance of the uretrocele. The adder head appearance is there. Okay. With left hydronephrosis, hydroureter. Not much, but this is calyces are pretty sharp. The ureter is normal in caliber. The predominantly you need to write about this uretrocele. Okay. Right. So what we see here is that there is marked dilatation of the posterior urethra. The bladder is also dilated, irregular, and you can see some diverticulae also coming out from the bladder, and the distal ureter is normal. So this is classic appearance of a posterior urethral wall with bladder outlet obstruction leading to this thing, dilatation of the urinary bladder and the bladder diverticulation. Copper bitten, silver bitten, mucopolysaccharidosis, craniostenosis, leukocidal. So definitely there is this leukocidal kind of appearance is there. But if you look carefully, you don't see the sutures very nicely here. Okay, you don't see suture nicely, and there is increased convolutional marking present throughout the skull. Hmm? So this kind of appearance would go with craniostenosis. That is the most appropriate diagnosis. Okay, due to sutural fusion, although you can see this posterior suture is seen, some Vermean bolts are also seen. And here, what you see, this lucent filling defect, actually, this is a post-operative case where some kind of, you know, procedure has been done in the region of suture just to open up the skull a little bit to relieve the pressure. But the diagnosis here is craniostenosis. You don't see the sagittal suture well in this. You don't see the this is basically open suture, and you don't see the coronal suture also. So craniostenosis would be the most likely answer. If you write J-shaped cella, looks like J shape, but you have to write this craniostenosis. Please repeat 35 number. Okay. So this is 35 posterior urethral valve. Craniostenosis. Okay. Any particular type? Well, that would depend upon the shape of the skull. Depending upon what suture is gone, you would have that plagiocephaly, scaphocephaly, dolichocephaly. But here, if you see, there is gross kind of shortening of skull. So most likely, most of the suture are fused. There is this big classification. Hemangioma, right? So that is the answer. You can see this clear-cut, well-defined lytic lesion with bony trabecular within. This is classic appearance of calvarial hemangioma, spoke wheel matrix, right? Okay, so diagnosis here is hemangioma, classic hemangioma of the calvarium. Thalassemia, here on end, thalassemia, thalassemia, thalassemia. Right, so all of you are saying it is thalassemia. Now look at this carefully. There is calvarial thickening, right? There is hair on end appearance, right? But is it involving entire calvarium? This part is okay. This part is okay. Only this part there is thickening in this. So would you like to revise your diagnosis? Osteosarcoma. Okay, osteosarcoma. That can be a DD, but this particular picture is characteristic of meningioma. Okay, meningioma produces focal calvarial thickening with this hair-on kind of appearance. Neuroblastoma met, this looks like an adult, so you would not put in a spotter, you would not put neuroblastoma. Osteogenic sarcoma, well, this kind of appearance can be there, focal wall thickening be there, but you won't see such dense kind of sclerosis, you would be seeing some matrix. Okay, so this goes with meningioma. The diagnosis here is diploic meningioma. Ewing's sarcoma, for to call it Ewing's sarcoma, we need to see an associated soft tissue mass, and you can't explain this density where you don't see the medullary cavity at all. You would see some permeative kind of lesion in the medullary cavity with mild expansion and a huge soft tissue component. So that is not happening. So this is not a round cell tumor. That is for sure. That will not come into differential diagnosis. I can, out of all these, I think one diagnosis I can accept, osteosarcoma. So perisutural mets would be showing that lysis of bone there. Here the dominant finding is osteosclerosis. So we move on to next. All right, so all sort of diagnosis coming here from chordoma, chondrosarcoma, and one more was there, mostly chondrosarcoma, so plasmacytoma. So what you see here, this is a huge lesion which is having this fluffy kind of calcification. This is skull base, adult patient with this kind of appearance. Most likely possibility would be a chondrosarcoma. Chordoma will not show such kind of calcification, and chordoma would involve the CV junction more often rather than this part. Although this conclavus is a common site, another point is this kind of thing, this kind of calcification is not there with chordoma. So chondrosarcoma is the best diagnosis. Okay. Last. Oh, 14 new messages. I didn't see. Yes, it is a myelogram. And if you look carefully, this is having this irregular kind of filling defect in the contrast column with displacement of the thecal sac, having this irregularity very nicely seen on this lateral view here, and also on the lateral view here. Okay, you can see this lateral view with a kind of as it is going up. And now again, if you look carefully, there is pedicle gone in this vertebra, pedicle gone in this vertebra, right? So this was a basically metastasis to the spine, which was indenting the thecal sac. This patient presented with paraparesis, and this kind of irregular appearance to the contrast column, this broken stick kind of appearance is suggestive of an extradural lesion. Here there is some confusion. This here it looks like an intradural extramedullary region. The two things: the first, that the bone is abnormal in the same area. Second thing, this appears more or less little bit irregular, and on the lateral, on these obliques and the lateral view, there is clear-cut irregularity that is demonstrated. This appearance is unlikely in an intradural extramedullary region. If you see this, you can still get confused, but after seeing these two additional views and with this bone lesion, the only diagnosis would be an extradural lesion, most likely metastasis causing compression of the thecal sac. Complete obstruction is there. I think this is the last part. So with this, I thank you all. 200 people still staying in this late night. Thank you all for being here. So Mitusha, you can take over.
Thank you, sir, for taking this exhaustive session. And these were really important spotters to revise with you under guidance. So thank you once again, sir, for your time and for agreeing to be a part of this event. And so the next session was tomorrow, but it's already past midnight. So I must say today we're joining back at 9 a.m. sharp. And please join us because these are also important sessions, and hope you liked whatever sessions we had today, and it was really a great learning experience. You can share your doubts, everything in the feedback column as well. And thank you once again. Thank you, Preeti sir. Thank you, Mani sir.
So you can close the session.